Good morning. My name is Darrell O'Sullivan, and I'm the treasurer of the Western Neuropathy Association. It is my pleasure to welcome you to the 2022 Annual Conference. This year, we have expanded our conference to 3 hours each day. The entire conference is a webinar, so you will not be seeing other videos, other people, except the presenters. To communicate with the presenters, use the chat button or the Q&A button to enter questions and comments. Also, there will be a survey at the close of each day when the webinar is ended. And we will have breaks throughout, as I know we all need to stretch our legs and move about because of our neuropathy. So I would like to take this opportunity to recognize and dedicate the 2022 Annual Conference to Bev Anderson. Bev is the co-founder of the Western Neuropathy Association. She has been our president and charismatic leader for many, many years. She constantly reached out to help those suffering from peripheral neuropathy. She searched every resource available to find ways to help reduce our pain and increase our quality of life. She dedicated herself to help us and to those who care for us. Although Bev Anderson's illness has resulted in her stepping down as president, her legacy continually inspires us all. Thank you, Bev, for all that you have done for us. So I'd like at this time to introduce Lindsay Campoy. Lindsay is the administrative assistant for Western Neuropathy Association and has been working for the association for well over 6 years. She's going to be helping out today with the Zoom as well as monitoring the attendance and questions. Lindsay?
Hi, everybody. Really excited to see everybody today. So today is going to be a lot like the other Zoom webinars that we've had in the past. We're going to have a speaker who's going to share their information with us. And at the end, we'll open it up to you all if you have any questions. You don't have to wait till the very end to send us your questions. If you're not as familiar with Zoom, at the bottom of the screen, you'll see 2 bubbles. You'll see one that says Q&A, and then you'll see one that says chat. You're more than welcome to use either of those to send us your questions. If you use the chat function, that'll kind of be an open forum. You can just type it in, and when we're done, we'll address it. Same thing with the Q&A. We'll see your question come through, and then we'll have the presenter or Darrell or one of our board members will then get to add in their answers. And again, we'll do that at the very end of everything. If you have any questions, put them in. You're also welcome to raise your hand on Zoom too if you have a question. So we might just ask you to place your question, type it into the chat box or into the Q&A. If you aren't able to do so, we can also make it so that you can speak if you would rather talk and ask your question as opposed to typing it. So just let us know. But otherwise, we'll just take it on from today, and you'll hear back from me in a little bit about fundraising. But otherwise, we'll go ahead and kick it back over to Darrell.
Okay, thank you. So the first thing I'd like to do to get going with the conference is to give you a little bit of an outline of what the schedule for the next 2 days are. So first, we will have a talk on neuropathy by Dr. Ji Zhang from UC Davis Medical Center in Sacramento, California. And then at noon, the board of directors will conduct an annual meeting, and we will talk about, we'll talk a little bit about some various issues that have to do with the department, the organization. And then at 12:45, Kathryn Stensel will talk about the rise and benefits of virtual support groups, joined by Lynn Carpenter, Chris Langdenfeld, and Don Tallman, who will also give experience relative to virtual support groups. At 1:15, Glenn Robotsky will give a presentation on patient stories. And then at 2:15, we'll end today's conference. But that's only half of the conference. So the next day, tomorrow, we will also start again at 11 o'clock. And I will be very pleased to introduce Glenn Croston, who will be giving us an update on Dr. Hammock's pain research and the status of the clinical trials that are ongoing. And then at noon, Glenn Robotsky will also give us another presentation on tools for patient advocacy. And at 1, John Phillips, our newest director, will give us a presentation on patient stories. And by 2 o'clock tomorrow afternoon, we will have gone through a tremendous amount of information, hopefully sharing lots of good things that'll help each other. And then we will be ending the conference. At the end of each conference day, we do want you to fill out the survey form, because it's very important for us to know what we've done right, what we've done wrong, and how we can improve. So it's now an opportunity for me to start the conference by introducing Dr. Ji Zhang from University of California, Davis Medical Center. Her specialties include neurology, neuromuscular medicine, neurophysiology. Dr. Zhang primary care areas include neuromuscular diseases such as neuropathy, myopathy, neuromuscular junction disorders, amyloidosis, motor neuron diseases, and her research interests include neuropathy, myopathy, myasthenia gravis, and familial amyloidosis. So without any further ado, I wish to welcome Dr. Zhang, and I will stop sharing and let her share her screen with us. So thank you very much for doing this talk and for sharing the wonderful information on neuropathy with us. Dr. Zhang.
Thank you very much for the invitation. I will start sharing the screen shortly. And I'm really honored to discuss with you, the whole community, about neuropathy here at Western Neuropathy Association meeting. As you know, I work at Neuromuscular Division at Department of Neurology, University of California, Davis. We manage various neuropathies in our clinic and hospitals. We would like to appreciate you for your interest to learn more about neuropathy. Hope this short talk will be able to offer a little bit more information to you today. So just to start my screen sharing. Can everybody see the screen good now?
Yes.
All right, good. All right, so this is a cartoon to show you our nervous system. As you know, our nervous system is quite complicated. The brain and the spinal cord are the central nervous system. Then what are those bundles coming out of the brain and the spinal cord? Those are our peripheral nerves. The peripheral nerves are the bundles distributing all over our body, collecting information from outside world and internal organs, and also conducting the commands from the brain and the spinal cord to perform the duties to keep our body function appropriately. So what does the nerve look like? This is a nerve in the arm, and you can see the nerve look like a bundle of electric wires. One single nerve fiber contains the outside layer we call myelin, and the inner part of the core we call axon. So the outside myelin protects the axon. Then what is neuropathy? So the neuropathy is the function abnormality of the nerves we just saw outside of the brain and the spinal cord. Then what causes neuropathy? Well, there are multiple reasons. There are two big categories of neuropathy. One category we call hereditary neuropathy, that is caused by genetic mutation. It could be from your parents or just some thing happen very suddenly while you were a baby, even not necessarily from your parents, because the human genome can have a spontaneous mutation. And the other category is called acquired neuropathy. That means it's not from genetic mutation. There are multiple causes, including trauma, infection, metabolic or nutritional abnormality. Sure, some toxins, including certain medications, can cause nerve damage. In the inflammation or immune-mediated process could also cause neuropathy. So what are the symptoms of neuropathy? Well, it's complicated. We have some patients may have a positive symptoms. They feel their nerves are irritated. They get tingling, burning sensation or pain, severe nerve pain. And sometimes some patients may have a muscle cramp that could be also from a neuropathy. There are negative symptoms, including numbness, weakness, and the loss of a balance. Some patients may have autonomic dysfunction. That means our internal organs are not working properly. For example, some patients will have too much sweat, or some patients will not have adequate sweating. The sweating glands dysfunction, and some people may have bowel or digestive problems like constipation, diarrhea, or indigestion. Certain patients may also have a blood pressure or heart rate fluctuations significantly, all kinds of symptoms. But we know all those symptoms are not quite specific, because certain symptoms like pain or muscle cramp could happen in other diseases, not necessarily neuropathy. The sweating gland abnormality is not necessarily quite related to the nerve damage either. As you know, constipation, diarrhea are very non-specific presentation. So that's not very easy for people to achieve the diagnosis of a neuropathy, right? So that is why it is important for us to visit doctors whenever you have the symptoms that could be neuropathy. Then why we would like to visit the doctors when there are symptoms of neuropathy, because we want to achieve early diagnosis to confirm those symptoms are caused by nerve damage. And also we would like to find the cause of neuropathy. Then we can start some early intervention to slow down the progression and improve life quality. Sometimes we may not be able to find the course of a neuropathy for everybody. We call idiopathic neuropathy, but we may be able to provide some management to help relieve some symptoms. Then how do we diagnose neuropathy? Well, for sure, if you have symptoms possibly suggesting neuropathy, you would like to visit a primary care doctor first, because your primary care doctor will be responsible for your general health. They can obtain some common lab tests to have the first screening, and then your primary care doctor may refer you to the neurology clinic. You do not really need to see neuromuscular specialists for all the neuropathy. The general neurologist can diagnose and treat common neuropathies. But when do you need to visit a neuromuscular specialist? For certain situations? For example, some type of a hereditary neuropathy. Right now, we have a few hereditary neuropathies that may have special treatments or have clinical trials that could be beneficial for certain hereditary neuropathies that are caused by genetic mutations. And if you have a certain, hereditary neuropathy need a special treatment, it's really helpful to visit a Muscular Dystrophy Association clinic that will offer many resources as well as multidisciplinary care. That means multiple specialists will be in that clinic to offer different managements to care about your neuropathy. And certain uncommon acquired neuropathy will have some special treatments like inflammatory or immune-mediated neuropathy, we always collaborate with rheumatology or immunologists to start some special immune therapy. And I would like to briefly mention about amyloidosis neuropathy. This is a very specific rare neuropathy. At UC Davis, we have a multidisciplinary team to manage this special neuropathy. And we collaborate with oncology, cardiology, specialty pharmacy, as well as nephrologists to help the patients with amyloidosis neuropathy. Then how can you reach a neuromuscular specialist? Well, your primary care doctor or your general neurologist could send referrals to neuromuscular specialists. And you can also look at the MDA website if your neuropathy condition is fitting the specific care within the range of an MDA clinic. You can find the care center list on MDA website. And also you can now Google online to look for neuromuscular division in Department of Neurology at different institutions nationwide. Kaiser is a private practice institution. It also has a neuromuscular specialist. Many academic centers, like the university hospitals, for sure they have a neuromuscular division. So those are helpful resources online. Then how do we diagnose peripheral neuropathy? You may realize that whenever you visit a neurologist in clinic, the neurologist always asks you, your clinical history. Even, we received a referral from your primary or general neurologist. We always want to ask your own story because we would like to obtain as much as possible about your information to help us guide the diagnosis. And we will perform physical examination, including neurological examination. We can order some lab tests. Those lab tests could be ordered by primary care doctor, like certain routine labs, blood routine, comprehensive metabolic panel, and A1C, glucose tolerance test, thyroid function panel. The vitamin test will be helpful. Usually we order B12 or thiamine. Sometimes we may add B6. We also screen for a certain type of inflammatory markers like C-derate, C-reaction protein, anti-nuclear antibody. We also perform a special blood test to look at the unusual protein band in the blood. As we talked previously, certain infections may cause neuropathy. So we also order some infectious tests that could cause neuropathy to see if there's any infection possibly can be treated to help the neuropathy. And many patients probably already know that EMG nerve conduction study is a really important diagnostic tool to achieve the diagnosis of neuropathy. Unfortunately, this is a painful procedure, not comfortable, although many people can tolerate that, but it's not a pleasant experience for sure. Some patients, we may perform lumbar puncture to collect the cerebral spinal fluid test for further evaluation, but we don't need to perform lumbar puncture for all the patients. Only a small percentile of the patients with neuropathy will need further evaluation from the lumbar puncture. Sometimes we may perform imaging study, including special ultrasound and MRI to look at the nerves, especially when the patients have trauma or injury to the nerves, that we would like to have a certain information to see where is the trauma, and is there any mass compression. Rarely we perform nerve biopsy to look at the nerve directly. We don't need to perform nerve biopsy in majority patients with a neuropathy. Only very, very unusual occasion we perform nerve biopsy. And usually I will talk to the patients to let them know what are the possibilities for the nerve biopsy will reveal. Nowadays, the genetic tests are relatively convenient, and we have to be careful when we have the genetic test done to look for the hereditary neuropathy, because the genetic test could reveal positive result that show which genetic mutation caused the neuropathy, but it could also report something not clear enough. The most common situation is a variant of unknown significance. That means certain nucleotide change was detected, but we are not sure if that change will cause abnormal mutation to cause neuropathy. So it's unclear when there is a variant of unknown significance. We don't really have special management or special interpretation. Sure, for the negative results will be reassuring. This is not hereditary neuropathy caused by genetic mutation. So I will talk a few common types of neuropathy to offer you a little bit more information. So the metabolic neuropathy is pretty common because many patients come to our neuromuscular clinic have diabetic neuropathy. The diabetic neuropathy can present about half of the diabetic patient population. There are different types of diabetic neuropathy, and it is a really common complication. So not all the patients with diabetes develop diabetic neuropathy, right? Then what are the risks for the patients with diabetes to develop a neuropathy? So first of all, the poor control of the glucose level. So it's always important to track the glucose level and make sure the glucose has been under good control to reduce the risk of diabetic neuropathy if a patient has diabetes. Also some other disease situation like hypertension, high cholesterol, obesity, and smoking are risk factors in patients with diabetes that could develop neuropathy. The most common type of diabetic neuropathy is what we call chronic sensory motor neuropathy. It affecting the sensation more than the strains. It look like the patients getting sensation abnormality in their lower extremity, like wearing long socks, or in the hands, when the neuropathy is getting worse later, like they are wearing gloves. The patients could have the sensation come up to the chest level or belly. Sometimes we call wedge-shaped sensation abnormality. Rarely the patients with the diabetic neuropathy can have the neuropathy occur very acutely or suddenly. Usually the patients have a really severe burning pain and hypersensitivity, even with a really mild touch. Those situation is worse at night, and because of the severe burning pain, the patient may get significant depression and weight loss. And usually the acute sensory neuropathy occur when the patients with diabetes have a very bad glucose control. Sometimes they may have an episode of ketoacidosis before they develop the acute sensory neuropathy. The chemotherapy-induced neuropathy is relatively common. That's one of the most common neurotoxic neuropathy, because nowadays with all kinds of chemo agents application to treat cancers, more and more patients start to suffer from the chemotherapy-induced neuropathy. The incidence varies differently in different chemo agents, could be 10 to 100 percentile. The risk factors for the patients who receive chemotherapy that will develop a neuropathy, including diabetes, alcohol use, and the poor nutrition, especially the B12 deficiency or certain type of an infection like HIV. The older patients usually are, tend to develop a chemotherapy-induced neuropathy after the chemotherapy because their nerves are more fragile than the younger population. So far, we don't know why the chemo agents will cause the nerve damage, and most of the time it may not be completely reversed. Even the chemotherapy was discontinued. So the chemotherapy-induced neuropathy may happen during the therapy or after the therapy. Sometimes it even happen, a few years after the therapy stopped. For sure, with a higher dose, the nerve damage will be more significant. So when the patients with cancer develop chemotherapy-induced neuropathy, the dosing could be readjusted if necessary, or the chemo could be switched to another type of a treatment. Nutritional neuropathy nowadays is less common, but it's still an important cause of peripheral neuropathy. The common deficits, including B12, thiamine, B1, B6, and vitamin E, usually is related to insufficient intake from the food or other nutrients, but it could be also from malabsorption. Especially some people get chronic diarrhea or have some chronic GI problem like atrophic gastritis, and some young patients may have toxic side effects from nitrous oxide abuse. That's another risk factor for nutritional neuropathy. It mainly affecting the sensation. So for the nutritional neuropathy, we offer the supplementation of the deficient nutrition, and also it's important to visit the dietitian to help the general health to have better nutrition, not only just the vitamin. So hereditary neuropathy is relatively more common in younger population, but that is a really important cause of the neuropathy. The most common hereditary neuropathy is the Charcot-Marie-Tooth disease. Some patients may be eligible for clinical trial. There are many different subtypes of Charcot-Marie-Tooth disease we call CMT, and some patients with CMT may start the disease relatively at older age, like 30s, 40s. So those are relatively uncommon situation, but we do have some clinical trials now could be potential hope for the patients with hereditary neuropathy, especially the CMT patients. Certain patients may have a hereditary neuropathy with a liability to pressure. That's another genetic disease. It requires the genetic test to confirm it. The familial amyloidosis polyneuropathy is the one that I will talk in a little bit details later, because this rare neuropathy start to have really exciting treatment in this, and this is now the only hereditary neuropathy that has special treatment approved by FDA. So what are the managements for patients with a neuropathy? Well, we always offer physical therapy, occupational therapy to help the weakness and also try to maintain the function. Certain patients may need a special orthotics like ankle brace if they have a foot drop and a wrist splint or elbow pad. So wrist splint usually is applied for the patients with carpal tunnel syndrome. Elbow pad will be helpful for patients with ulnar neuropathy that compress at the elbow. Those situations usually happen when the patients are, using the hands a lot or have, the habit to compress the elbow or wrists repetitively. We also have certain medications that could help neuropathy symptoms, like gabapentin, pregabalin, Lyrica, are the first-line treatment for patients with neuropathic pain. Duloxetine is antidepressant, the commercial name called Cymbalta, is also used to treat neuropathic pain. Nortriptyline is another type of antidepressant that will be helpful for neuropathic pain or tingling. There are some, anticonvulsant medication used to treat the seizure that may be applied in some patients, rarely, to help to control the neuropathy symptom of tingling pain. Alpha-lipoic acid is not a medication, it's an antioxidant. It may help improve the symptom of numbness, tingling, and pain. There is a small clinical trial done before in patients with diabetic neuropathy showed some improvements of pain control, although individual response could be different. Some patients do not like to take medications because the side effects profile. So we also recommend a certain type of a topical cream. Lidocaine, capsaicin creams are the commonly used one. Those topical cream will not really be long-lasting, but will be helpful, especially the patients have significant side effects to the oral medications. So neuropathic pain control is a common question in our clinic. Although we are not pain specialists, we usually talk with the patients about the medication choices, including the one we just talked in the last slide. However, some patients may not be able to having good response for those commonly used medication for neuropathic pain, or they could not tolerate the side effects. So then we send the patient to pain clinic to specifically address their pain control. The pain clinic have medical choices like medications, all kinds of medications, including the oral medications or infusion medications. But the pain clinic could also offer some non-medical managements, including behavior therapy or biofeedback. Nowadays, California also approve alternative medicine to help the neuropathic pain control. So we do have patients at a pain clinic who can receive transcutaneous electric nerve stimulation TENS unit to help reduce the pain. And certain patients may try acupuncture. And there are some reports about the application of a transcranial magnetic stimulation to help pain control. Although right now, I don't think our institution, University of California, Davis, is offering the transcranial magnetic stimulation. It could be possible choice in future. Maybe this need more research, also the clinical trial so far. So there are certain special treatments for some unusual, neuropathy or different types of neuropathy. Like the diabetic neuropathy, as we mentioned, glucose control is really important. Nutritional neuropathy, we emphasize the nutrition supplementation. In the toxic neuropathy, for sure, you want to stop the toxin exposure. Infectious neuropathy, we will treat the infection. The inflammatory or immune-mediated neuropathy will need immunotherapy. The immunotherapy itself does not regrow the nerve or repair the nerve. The immunotherapy just reduce the inflammation or cool down the immune reaction to let your body repair the nerve by itself. But that's important because with ongoing inflammation, the nerve damage will be more and more significant. The immunotherapy may stop the inflammation or slow down the inflammation to offer time window for the nerve to repair. Traumatic neuropathy, depends on what type of the trauma, like a carpal tunnel syndrome. If that's severe compression, the patients could improve with a compression release surgery. And some patients have a really significant injury from motor vehicle accidents. We may refer the patient to plastic surgeon or neurosurgeon to do some special nerve repair. But the generalized neuropathy, like a diabetic neuropathy, we don't have the methods to do any specific nerve repair. So now I would like to talk briefly about familial amyloidosis polyneuropathy. The abbreviation is FAP. This is a really rare hereditary neuropathy. Most of the time, the patients have a family history. It happens in each generation. That means, it happened in grandparents, and then it occur in parents, then come to the children. But there are sporadic cases reported before. It is caused by transthyretin TTR mutation. This is a worldwide disease. First, it was identified among Portuguese, and then we identified this special hereditary neuropathy in the United States. In the other European or Asian countries, African Americans or African countries. So this disease will affect multiple organs in the systems, including nervous system, gastrointestinal tract, heart, kidney, and eyes. This is a rare disease. Previously, without the treatments, the prior treatment is mainly liver transplantation. Without the treatment previously, the patient could die within 5 to 10 years with the rapid progression of neuropathy. So we do have the new breakthrough for the treatment of disease, applying the genetic therapy. FDA has applied RNA interference treatment to treat FAP. Nowadays, we have another strong gene editing tool, CRISPR-Cas9. That's the really strong tool to edit the human genome or other animal genomes. So Dr. Carpenter and Dr. Doudna are the pioneers to develop this strong genetic editing tool, and they won the Nobel Prize in Chemistry in 2020. So there are some other scientists that also made significant contributions to bring this strong tool to our human disease application, including Dr. John from MIT and Dr. Church from Harvard University. So now I would like to show you a video how this revolutionary tool is affecting our advancement of the genetic therapy for the hereditary neuropathy. Okay. Let me switch to another screen. All right, let's just go back to my prior slides. Well, the question is when and who will apply this tool? Well, for sure, we would like to use this strong tool carefully in the patients with a certain hereditary disease will be able to benefit the revolutionary therapy. Right now, the FAP clinical trial for the CRISPR-Cas9 gene editing system is only in phase 1, and there were 2 groups of patients. 6 patients received the treatment with this strong gene editing tool. The patients had the abnormal protein knocking down, and then the dose of the concentration of the abnormal protein production significantly decreased after just a single dose of the treatment. So we no, this is not perfect for the tool. The tool is not perfect so far, but we are still, working hard to see if we can make the treatment, better. And at the same time, really be careful, don't apply in certain situation that will not be legal. Okay. All right. So this is my presentation. Thank you very much. And I would like to acknowledge in my department for the support of the neuromuscular clinic, as well as my colleagues, the collaborators to help care of the patients with neuropathy in the audience. Thank you.
Thank you very much, Dr. Xing. At this point, we would like to open the floor to questions. And I know there's a few of them in here. So unless somebody else wants to do this, I'm just going to jump in and start asking some questions here that are in the Q&A. One of our participants asked, can you give an example of metabolic nutritional abnormalities as a cause of neuropathy? And I think you did, but I mean, you might want to reiterate some of that.
Well, the common metabolic abnormality cause neuropathy is diabetes and some other metabolic abnormality, including, uremia, the kidney dysfunction. Nutritional abnormality is pretty common, including multiple vitamin deficiency. The one that I listed in the slides, are the commonly encountered one, B12 or thiamine neuropathy. Okay.
And another question is shaky hands a symptom of neuropathy?
Well, this is a very nice question. So I will say, if you refer shaking hands as tremor, then usually tremor is not a symptom of a neuropathy. And some patients could have a little bit tremor when they have a certain type of a neuropathy. We do see some patients with a CMT, very special subtypes of a CMT present with a little bit mild tremor. But the tremor is not the only symptom for those patients with a special CMT.
Next question is, why is there such an inconsistency in testing for neuropathy by different neurologists, different findings and conclusions?
I'm not quite sure about this question. Like the blood tests, so different labs have different standards. That is true for like the blood tests, but usually they will offer some reference range in different labs. The EMG nerve conduction, I will say we do have some different standards in different institutions, or the normal range, because the human population is so heterogeneous, or we are not the same person. No, we try to find a normal range. So usually we define the normal range based on a population around our community. But you can see we have a different ethical backgrounds in the it may exert a certain difference for the normal range. For example, so I used to work at the East Coast. I can tell you the normal range of the nerve conduction test is different from my current lab. But both institutions are, credentialed institutions. And sometimes we may see certain, different criteria, but in general, our standards are similar. We cannot say, they are the same all the time. Because, for example, some people, with a small size, you cannot really imagine the nerve diameter will be the same as a larger size person, right? In theory, nerve conduction velocity or nerve response amplitude will be sort of like, the same, but that's really just in theory. So the normal range could be, evolving over time or over years. And we do have some, updates of, the diagnostic criteria for different types of neuropathy over time. Like, the one we probably, have updated the diagnostic criteria several times in the past 20 years, like a chronic inflammatory demyelinating neuropathy. This is a case. So it's not an issue with, sort of like different opinions, but I think also the disease itself evolving. So initially the test could be normal, but over time with the symptom progression and the test, when you get repeated, it could be different.
Okay, thank you. So the next question is danger of nerve biopsy.
Well, this is an invasive procedure, so we usually don't, do this procedure unless this is truly necessary.
Okay, and the next one is, does elevated A1C and sugar consumption cause peripheral neuropathy symptoms in patients who are not diabetic?
Oh, well, this is a very good question. This is a situation with a pre-diabetic, condition. So we do have a patients who have a neuropathy with a pre-diabetic condition. Is there any established causal relationship? I can only say, the underlying etiology of diabetic neuropathy is not quite clear, but the glucose level has been, not really healthy for the nerve in the long term. So even the patients are not meeting the criteria for diabetes, but the glucose level was not normal. That may cause a certain pathophysiological change that may not be good for the nerve health. Is there any, established causal relationship? I will say we don't have that, strong evidence, but it could, exert some, bad effect for the nerve health in the long run. Even the glucose level is just relatively elevated, not to the range of diabetes range.
The next one is, can some nerve damage be repaired, or more specifically, can neuropathy be reversed?
Well, depends on what caused the neuropathy. Certain patients with traumatic neuropathy, we do have some surgeons could do nerve repair, but we don't have the approach to repair the diabetic neuropathy. Can neuropathy be reversed? I will say in majority cases it cannot, especially when the damage comes to the inner part, the inner cord, axonal part. The outside part, myelin damage, could be repaired by the body itself. There's no medication specifically regenerate the nerve or myelin. it's your own body. But usually the myelin repair by your own body may not be complete.
Okay, the next question is, what about cryoattenuation?
So I'm not quite sure about this question. Is the management's sort of like, use a certain the cryotherapy to reduce the nerve pain? Because this measure I had never applied, so I cannot really comment on this one. But I heard some patients mention about intervention. I'm not sure if the pain clinic is doing this intervention. At least at UC Davis, we have not adapted the cryoattenuation.
Okay. Next question is there something we can do to regrow, repair, or our peripheral nerves? What are the possibilities and the timeframes? I have unknown peripheral neuropathy, as many do.
As we just mentioned, in general, we don't really have any medication to regrow or repair the peripheral nerve. So for the traumatic neuropathy, like, a patient gets the nerve caught from a car accident, the plastic surgeon or neurosurgeon may be able to reconnect those, nerve damage.
Mm-hmm.
But, for the general chronic neuropathy, we really don't have one, that can be applied.
The next one is, what is nitrous oxide abuse?
Well, this is not that uncommon now. So some people may, sort of like inhale the laughing gas. Well, if you are in the dentist, office to do procedure, get some, some laughing gas is not a big issue, but some people are sort of like, to inhale laughing gas intentionally for their spiritual, is sort of like a drug abuse. So that nitrous oxide abuse could potentially cause B12 deficiency.
Okay. Is EMG a negative? If EMG is negative, can there be an impediment of nerve at the ankle area? Let me read that again. If the EMG is negative, can there be an impediment at the nerve at the ankle area?
I don't really quite understand this question. So EMG test is more functional test. It does not showing the structural abnormality. We have to be aware of that. The structural abnormality, the EMG test will not be able to see the impingement or the nerve damage in certain structure directly. It's just showing the function damage. If you are thinking, there is a possible nerve compression at the ankle, EMG will be helpful for the functional part to see if there's a compression. If you would like to see structurally the compression, then the imaging test will be helpful.
Okay, the next one is, I think you basically answered this one, but will there ever be a real treatment for PN?
I'm not quite sure about this question. If we do have a treatment, the current treatment mainly targeting on the symptom control.
Yeah. Okay. So another one said, I meant to say unknown etiology, I guess having to do with the previous question. I'm not sure how to connect it. What about platelet-rich plasma therapy?
As far as I know, we have not really applied this type of a therapy as the treatment of neuropathy management.
Okay. If neuropathy is circulation related, can the body repair nerves with circulation improvement?
I cannot really say neuropathy is caused by circulation problem because right now the course of the neuropathy, as I listed in the presentation, are not really including the circulation. But it may, have a sort of like, a certain situation, the microcirculation, like some patients with diabetes, the microcirculation may not be good, then the nervous in that small area could be, impacted, but we don't know because we don't have clear answers for all those questions. We have, scientists doing researches to try to understand all the courses, but I don't think we have, the clear answers for all the courses of the neuropathy.
Okay. I just want to ask, let's see, there's another one here. I just see a new one that says, in the rebuilder unit, which is a mechanical device that's used to help rebuild nerves, there are 3 settings. In your opinion, which is the best for peripheral neuropathy? TENS 1, EMS 2, and 3 is 7.83 hertz. I guess I'm not sure how to answer this, or even what, unless you understand and have a working knowledge of the rebuilder.
Well, we usually don't, deal with this situation because usually if a patient need to, do certain type of whatever we call non-medical approach to help the peripheral neuropathy, I generally refer the patient to pain clinic or rehab department because they are the experts dealing with this type of instruments specifically, and our our major task here at Neuromuscular Clinic mainly is to make the diagnosis and offer the common medical management for the symptoms.
Okay, thank you.
Thank you.
Now, just one last thing I'm going to ask is anyone that has any more questions or comments to please quickly put them in. If not, we will proceed on. So at this point, I don't see any more. So I think what we're going to do is say thank you so very much for your presentation. It's very appreciated. And we appreciate that you took time out of your busy day at the medical center to provide this good overview and comprehensive review. Thank you very much again. And please have a very good day. And thank you for participating in our virtual conference.
Thank you. I greatly appreciate this opportunity to share the information with the community, and hope we have better research in future and more advancements in the neuropathy management. Okay.
Thank you.
Thank you. Hi. You all have a good day.
All right. Thank you. Okay, so let's go on now. So I think we're going to talk about some door prizes now.
Yes, we're going to talk about door prizes. I'm Kathryn Stensel, one of the directors for the Western Neuropathy Association, also support group leader, editor of the newsletter. I see by looking at the participant list that I at least know 2/3 of you. So hello to everybody. It's so great to have you here today. So we are going to pump our energy level up and we're going to give out some door prizes. Everybody ready? Okay, so what we've got is 1, 2, 3, 4, 5 books on peripheral neuropathy, something we all want. And then you're going to get an extra book, Chicken Soup for the Soul, Inspiration for Teachers, because this has a story that Bev Anderson wrote. So we're going to, it's going to be like a 2-for-1 thing. So what we're going to do is we're going to spin the wheel and you'll see if your name comes up. So I am going to share my screen. Let's all hope that this works when I do this. Yay! Okay. And now I'm going to go full screen. All right. And we're going to spin the wheel. And it's landing on Dorsey Cartwright. I don't know if I saw Dorsey's name in here. Is she in the participant list? I can't move all my people around. Does anybody see her?
I was going to say either we could see her, or if Dorsey is there, she could throw something into the chat box to let us know she's there.
Right.
It looks like she's not signed on right now.
Okay. All right.
There's a Carl Dorset.
No, that's a different person because
Okay.
Carl was the one who was asking some questions. Okay. So, well, we'll just close that. Okay. Because we're going to get 3 winners. So we're going to spin till we find. And the next is, Sally Hearn. I know I saw Sally's name someplace. Maybe it was in the registration. Is she here? Yes. Yay! Okay, so I'm removing Sally's name out. Sally will be going back to the slide that has the books on it, and then you can pick which one you want. Okay, so we want to get 2 more people. Spin, 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 spin. And who do we have? Oh. Lolene Abbott. And I don't know. Y'all look in the participant list. Everything's covered up on my screen because I have the spin the wheel on.
Lolene's here too. Yep.
Lolene. Yay, Lolene's here. 2 people. All right, we're going to remove Lolene's. And 1 more person. Spin, spin, spin. Oh man, that was really close. Okay. Rick Donovan. And what about Rick? You see?
I don't
No?
see Rick.
Okay, then we're going to
Do 1 more.
1 more. Spin, 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 spin. It's like we're in Vegas. Spin, 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 spin. Spin, spin. Jean.
Jean.
Jean is here because I have spent the last 15 minutes with Jean trying to get her here. She is on the phone, so I know she is here. So put her down as a winner.
All right.
Jean, it worked. We spent all that time. We got you on and you won one of the door prizes. Okay, that's awesome. That is awesome. Okay, so I'm going to stop. And so Daryl, if you can bring your screen back.
I sure can.
And let people look at the door prizes. And if you guys can look to see, and there'll be an opportunity for, we're going to do this twice more today and 3 more times tomorrow. So, but pick out, the really good one is this one right here, the one that's got the 2 feet. Peripheral neuropathy, when the numbness and the pain won't stop. That's a really good one by, okay. And then we've also got, let's see, all these are good. So pick something out and put it in the chat if you can, or send me an email, whichever way we want to do. And then we'll send you your books.
It also means that if you hang out here long enough today and tomorrow, you have pretty good odds of getting one of these
Pretty good
books.
odds of getting a book, I tell you. Okay, So let's go on to fundraising.
All right. So, oops. Here we go.
All right, everybody. So hi again, my name is Lindsay. I'll be talking to you guys today and tomorrow about fundraising. So first off, I want to thank everybody who's able to attend this weekend. And for those of you who are joining us live for the live broadcast, we appreciate you being here. So in the month of May, it's Neuropathy Awareness Month, which is why we like to hold our annual meetings and conference in the spring each year, is to draw attention to this particular time of year, specifically May, to draw attention to neuropathy, and then also to provide you all with services, education, support for those that are sufferers or friends and family of sufferers. So why do we fundraise? The WNA is a nonprofit, public benefit 501c3 corporation. So we rely on financial support of our members and our attendees in order to provide the things that we provide and fund the things we do. So I will mention off the top that all contributions, whether it's your member dues or any other additional contribution, is all tax deductible. So a really nice perk is if you give us money, it's tax deductible. So that's one less thing that you need to worry about. So our board, our committee members, our advisory members, our support group leaders, they all work and donate their time and their talent to WNA. But beyond that, we still have organizational, operational, and programming expenses that allow us to provide things like this conference today. So the success of implementing our strategic plan, and as well as the WNA vision and mission, depends on increasing our revenue each year to be able to maintain this level of help for you all. So you might ask yourselves, if you're already contributing via your monthly membership dues, why do you need to donate more? Well, your membership dues absolutely do help put a big dent into our operational costs year to year. But as you'll see a little bit later, when we provide our financial report in our annual meeting, there is still much more to cover cost-wise. So that's why we depend on additional contributions from our members and our support group attendees to keep our lights on, so to speak. So I'll give a couple examples of what different levels of your contributions can do for WNA. So for example, if you wanted to donate $10, that can help support our website for about a month. If you were to donate $25, that can allow us to print about 200 copies of our informational brochure that we send out to people that are interested and to our support groups. $50 helps to support our local support groups for about 6 months and can cover the cost to hold a Zoom webinar like today. $75 pays for about 3 months of our toll-free helpline that you can call in. $100 donation would be able to allow us to print and mail about 100 copies of our monthly newsletter. And about $250 would provide us with enough fundage to help get a new support group going. So different levels of support can help us do different things. Obviously, the more the better, but anything that you can provide to us is going to help us do these things that we provide for our members and for neuropathy sufferers. So thankfully, we have a longtime member and support group leader who has given a very generous donation over the last few years. So Daryl, I'll have you go ahead and advance one slide. So we're very excited and very grateful to have her donation provided again this year. And we'd like to give her an opportunity to speak to you all about her donation and speak to the attendees today. So I would like to welcome Kathy Clemens to the floor.
Hi, thank you. Thank you, Lindsay. Excellent program. I've had neuropathy for probably 13 years, and about 10 years ago, I learned about the Auburn Neuropathy chapter, and of course I know Bev Anderson very well. She's an incredible individual. She's done so much for research and helping start all of our chapters that we have. And so this year, I'd like to make an offer of $1,000 on a matching basis for anyone that would like to contribute. I know that we need keeping our chapters going and the education that we're learning and this wonderful annual conference that we have every year. And I just want to say thank you so much to everyone that's on the board, but especially to Bev Anderson for making this all happen for all these years and all of her work. And so if everyone could please help match my $1,000 donation, and please get the monthly newsletter. It's incredibly valuable, and I appreciate anyone that can help match. So thank you so much.
Thank you.
Awesome. Thank you so much, Kathy.
You're welcome.
So as Kathy said, our goal here is to match her donation. So her donation of $1,000 has already gotten us halfway there. So my challenge to all of you is let's match it. So our goal for the whole weekend is to meet and or surpass that $2,000 mark. And so on the screen, you'll see there's a couple different ways that you can donate. So one of them is if you would just like to send us a pledge, which is just a pledge that you will donate, whether it's via credit card or if you want to send in a check. You can send us a chat using the box below. Just make sure that you set the chat over to the host and panelists if you want to stay anonymous. We don't want to put any judgment on anybody for any amount that they're about to give, but you can use that and send us a chat with your pledge of the amount that you would like to donate. And I have this very sophisticated ledger that I'm keeping track of all of our donations. And then at the end of the day, I will send us everybody an update on the thermometer so you can see where we're at. So you can send us that pledge. You can also donate directly through our website, which is pnhelp.org. And I'll put the link in the chat as well if you'd like to go straight there and just do a donation with your credit card payment. Again, there's no minimum. All totals are welcome. So you're happy to do that. Or you can also email me. My email is admin@pnhelp.org, and you can send me an email. So any of those ways will do it, and we will keep on going, and I will check back in after our next wheel of prizes, and I'll give you guys an update.
And if you, I see that somebody has already donated $100. So we are 1/10 of the way there. She donated in the chat.
Okay. So thank you very much for all of the efforts and wonderful thoughts about Bev, and also the generosity of starting this donation system going. And we really, as an organization and as those who want to support and help the people who suffer from peripheral neuropathy, appreciate everyone's efforts. So the next part of our Western Neuropathy Association annual meeting conference is going to be our 2021 annual meeting. And during this annual meeting, we are going to primarily reintroduce the board of directors. Many of you already know some of them, and we have some new members that I think you would be very happy to know. As the treasurer, I will give a 2021 financial report because I think it's very important that the members of the organization know what our finances are, where the issues and good things are about finances. There will be a summary of membership and what's going on with membership. And then there will also be a summary of what's going on with the support groups and what the possible future looks like for our support groups. Again, feel free to ask questions, but we'll bring them up at the end of the meeting agenda. So this is the board of directors of the Western Neuropathy Association. And as you know, Bev Anderson, our very astute and amazing president, is now retiring after many, many years of unbelievably dedicated efforts on our behalf. The vice president is Karen Palastri, and Karen has been with the organization for well over 10 years. And again, my name is Daryl O'Sullivan, and I'm the treasurer, and I've also been with the organization over 10 years. Pam Hart is the secretary, and I don't know if Pam's online, if she wanted to say anything, but Pam, if not, Pam has been here with us also for a long time, for well over 10 years as well. One of our newer directors who you hear and interact with a lot is Kathryn Stensel. She's also the new Neuropathy Hope editor, and she does a fantastic job at that. Kathryn, did you want to say anything?
Well, I did want to say that I have not been on the board for over 10 years. Although I am not the newest person, so the people beneath me have less on the board than I do. But I do want to say that I do have neuropathy also, and as does Daryl. And so, and you know, I find that being on the board and having neuropathy does give you a unique appreciation for the work that we do.
Yeah.
And I really appreciate everything that all of the directors do.
Thank you. Also, I'd like to introduce Glenn Robotsky. He's also a new director. And like, you know, what we're finding out is we become not just a regional organization, but national. So Glenn, you want to give us a little bit of info on you?
Yes, I am New York born and raised, and you'll see a little bit more about my biography with one of the presentations I'm going to do. But I am a person who's been suffering from neuropathy and basically small fiber idiopathic, and I've been doing that for about 18 years now. Mine's a very special case. You're going to hear about that later. The joke with me is that the doctors say when you hear hoofbeats, think horses, not zebras. I'm an okapi. And basically having such an unusual neuropathy presentation led me to do a lot of research, become an advocate, petition to become a member of the board of directors. Hopefully that advocacy and expertise will bear fruit in the future. One of my major initiatives, as many of you out there probably know, is that neuropathy, even though so many people suffer from it, is not something that's very high up on people's radar. Basically, people don't know what it is. Even a lot of doctors are not familiar with it. That's something that needs to be halted. And hopefully, you know, efforts that this board will make and this organization will help in that regard.
Thank you, Glenn. And last but not least is our very newest board director, John Phillips. John, do you want to give us a little bit of background?
Yes, more than happy to. My journey with actually being diagnosed with neuropathy started in 2020 with non-link dependent small fiber neuropathy. And then later in August of 21, I was diagnosed with atypical sensory CIDP. With these conditions and how it affected much of my life, and now knowing more about neuropathy much earlier in my life, I've learned to advocate for myself, and through my advocating, I'm trying to help others that are struggling with this fight. That brought me to eventually volunteer to lead the open discussion for the WNA and eventually to become a board member.
Okay, thank you, John. Appreciate it. So this is the board of directors, and I want you to know that we are all dedicated very much. And Bev has been the most unbelievable example of how to go about helping and searching for things to help each of us, because we're all a little different and we all have a little different problems, but we all work towards the same goal, and that is helping find ways to make your life better and those suffering from peripheral neuropathy. So the next item that we're going to talk about at this meeting is, since I'm the treasurer, I guess I'm the one who should be the one talking about this, is to give you a sort of a summary, a financial summary for last year. So I'm going to give you a little bit of information about revenues and expenses, and then we'll talk about some of the questions or issues that relate to each of them. So under revenues, there are really four primary sources of revenue. Dues, which in last year we received $7,550 worth of dues. In contributions last year, we received $43,240 in contributions. The vast majority of that came from two separate donations. We also received $9,000 from the thrift store donations that many of you participate in Northern California. And then we also received a $5,000 grant from the state of California as a COVID-19 relief grant. So in general, we had a gross revenue of $64,790 in 2021. In expenses, we have expenses, a number of different expenses. The newsletter cost about $7,320 a year to produce. Administrative expenses are indeed the largest expense because that's the manpower of the association office that does all the little things day in and day out to make sure the organization operates, to get out information, to follow up and do all types of different things. The next item is fundraising, and we spent about $1,950 on fundraising last year. We spent about $220 on dues and subscriptions for the organization. Office supplies and fees, about $3,320. And insurance costs are about $2,550. Outside services, about $1,350, and website costs overall were $1,520. Many of these are flexible a little bit, but mostly fixed. And so we had an overall expense last year of $36,780, which left us at the end of 2021 a net of $28,010. That may seem like a lot of money, and it's a nice thing that it's a positive number. But I want to reiterate what Lindsay was mentioning, and also what I mentioned and pointed out a little while ago, is that without the contributions and without those two generous people who gave us huge amounts of contributions in 2021, this number would be very low and perhaps even in the red. So contributions beyond dues is a very important and essential part of making our organization operate and continue. So again, we will answer questions about various parts of this as we go through this meeting. So I think we're going to talk now. I think Kathryn's going to talk about membership.
So for membership, at the end of last year, we ended up with 397 members. I know that at one time, the organization had over 1,000 members in its really heyday, but I think we're doing pretty good. I understand that at least since 2015, 2016, that we have been increasing our membership steadily. This chart here shows the amount of new members that we've had each year. I was really interested in that to see what the effect the pandemic had on us. And as you can see, in 2021, we added 53 new members. I mean, that's like, what is that? A sixth, an eighth of, I don't know, of our organization. That's a huge amount. So we, as an organization, we're still meeting the needs of the neuropathy community. And you can also tell, looking at this little bar graph I put in here, how our membership is also expanding geographically. Excuse me. We've gone beyond what the original idea was for the Western Neuropathy Association, as far as beyond California, beyond the West Coast, and going to other parts of the US. Can you do the next slide, please? Mm-hmm. So for local support groups, we have had some difficulties in 2021. Of course, the pandemic came and affected a lot of our local support groups, such that now we only have 2 in-person monthly meetings, Auburn and Santa Rosa, and Houston has a quarterly meeting that they do. For the rest of our support groups, can you go forward? We have 3 of them and maybe 4 of them that are planning to meet. Castro Valley is still interested in maybe going virtual. Sacramento, the lead of that, is trying to get her job situation in line so that she would be able to commit to a specific day and time and start leading Sacramento. Grants Pass in Oregon is actively trying to restart. They're having a meeting. They should have had their meeting in May to get the group members together and talk about going forward. And on the, if you'll hit that. So, but along with having all these positives, we do have a lot of negatives. And I'll talk about the reason that a lot of these groups have disbanded in my next talk. But you can see here all these groups in California that are no longer meeting. They are disbanded. The group in Las Vegas, the person there had family situation. person in Austin. That group never really got off the ground after Texas came into the WNA. And the last one, but we're still trying to connect with these last groups. I think we did finally get I don't know if it's San Diego or South San Diego. And we found out that the leader on that is really interested in maybe going virtual also. So that's really good. So we've still got some hope on getting some more of these groups going. Now the next one, next slide. So besides those really 3 in-person support groups, we do currently have 3 virtual support groups going on. And we don't really designate these by geographic locations anymore, although there was the first one in Monterey, California, and the last 2 were in Houston, Texas, because the membership for those has just expanded across the US. So now we talk about them as far as when they are in the month. So we have the 2nd Saturday, the 3rd Wednesday, and the 4th Saturday groups. And I'll be talking more about that in the next presentation. And if you click once more, maybe twice more, and then once more. So, and the good thing about these virtual support groups is, you're not limited by transportation. All you have to do is just pick a time and just sit in front of your computer and make sure that, and then you can attend. So you don't need to worry about the weather. All you need to do is just sit down and join one of our virtual support groups. And I think that is the end of the annual meeting portion of our annual conference. I haven't seen any questions. Are there any questions from the attendees about the annual meeting portion? Oh, I know, there was one question. There was the question about the thrift store, and that the person wanted to know a little bit more about that, and if there is a way that they could be donating to the thrift store. Daryl, do you know about that?
Well, yeah, the best way to find all that information out is to go to the website, pnhelp.org. And in that particular that website, you can find out an actual email address to contact the thrift store, and find out more specific information about your locations, because it's a little more complicated than for me to be able to just tell you what areas are what. There are also ways to even contact them by phone, but the easiest way is to email them at a Gmail email address. Lindsay, you wouldn't happen to know what that is right offhand, would you?
Yes. So if you want to reach out to them about scheduling a donation in your area, you can reach out via email. So their email address, it is WNA donations@gmail.com.
Yeah, and they will get you back lots of information about their schedules and everything
Yes.
else.
And the main way they schedule is in advance. So they have like a map out area of Northern California or areas that they can pick up. So usually what they do is mail out, it's a bright orange postcard that'll have WNA on it, and it'll have a little cute picture of a truck and tells you exactly what day they will be in your area. And then you can set out your donations curbside. They have a couple of rules of what they can and cannot take and how the donation needs to be prepared. But they can put that out for you. And then once you get your postcard, you'll see the information. But otherwise you can email them and see maybe the next time they will be in your area or not, or just to get more info. So again, that's WNA donations@gmail.com.
And this is just for Northern California, right? Yes. It's not for all of WNA. It's
right.
And it's really cool that this group does have this relationship with WNA to where they share half their profits. Is that how it is with us? Mm-hmm. Or all their profits, something? So
it's a portion.
No, it's an actual percentage. It's a relatively set percentage that they share with us. Yeah.
Okay.
And I just added the email into the chat if anybody wants to get in contact with them, or if they have a question about how to donate, so you can get in contact with them. And they're usually pretty good. I think they have about a day turnaround time to answer any questions.
So we do have a question, it says, I'm in Austin, Texas, and would like to become much more involved. I appreciate your efforts and the great presentation today. So, well, you just need to get in contact with us and we'll be happy to help you get involved.
Hey, Dana, I remember you from NATX when you gave your presentation. And I will be glad to contact you and see if maybe you can do something else in Austin, or you can work with us. That would be awesome. Dana has a really great story, and we'll have to get her to share that with us.
Mhm.
Thank you.
Thank you. I think that's all the questions I've seen.
It looks like someone raised their hand.
That was Lynn before, and somebody else.
Let's see. Lynn, if you had a question, you're more than welcome to add it into the chat box or the Q&A. If not, we can keep going. Lynn, you're more than welcome to send us an email with a question too, if you're unable to navigate around Zoom.
She knows how to do that. Well, let's go ahead and we'll go on to the next part of our conference. I'm going to talk about virtual support groups. And if you just need to go on to the, oh yeah, I am doing that. It is mine, isn't it?
Yeah, it is.
I was going, Daryl, why are you stopping sharing your screen?
Well, now I know why.
Yes, okay, never mind. You know, I was getting ready to say, hey, you need to stop that. All right.
Whoops. There we go.
Okay, are we good now? Yes. So and remember, this is from the Western Neuropathy Association's point of view, but I want to talk about the kind of rise and benefits of the virtual support groups. And so we're just going to, it talks about kind of changing times, and just want to talk about what happened over the last couple of years. And in February 2020, which was right at the start when the Texas groups joined the Western Neuropathy Association, WNA had 25 in-person support groups. But also, Bev had just about started to change some of her support groups to teleconferences. It was getting more difficult to get out because of the weather and traveling to some places. So she was already thinking about transitioning away from in-person to essentially things that were more virtual, even if that's just over the phone. And then COVID-19 hit. And all of a sudden, we're all worried about social distancing. So like in-person support groups, gone, stopped, anything where you're going to go and be around more than one person has been put on hold. And that's exactly how it was for us. But because we still need to meet the needs of our peripheral neuropathy community, Bev did start with more teleconferences. I believe there were maybe 5 or 6 teleconferences that were going on within the organization, so that we're still able to connect, share our problems. Then we all started hearing about Zoom. And this was really new to me too. What is this Zoom thing? I think I finally had a Zoom Christmas meeting gathering with my family. But more and more about doing Zoom support groups. And so we found out that Dr. Donovan was starting his group again in Monterey, but he was starting it through Zoom. So he did that for several months. And then I felt like he shamed me. So I had to start with the Houston group. So we started doing our Zoom meeting. I remember the first time we had our meeting, we had 10 people come to the meeting. And I was so excited. We had 10 people. It didn't take us very long until we had 25 people. And I said, okay, we just have too many people now. So why don't we start another group? So we did that. Actually, we extended our time period from 1 hour, I think, to 2 hours. And we added a whole nother group. And that group is now up to 25 people too. So it has really worked having the virtual support groups. So just to talk again about the problems that the in-person groups have seen, COVID, it's really taking its toll, but in part because people weren't going to the meetings, in part because leaders, when they saw that when they had their break from their meetings, they really didn't want to go back. It's hard to lead these meetings. When you do these monthly meetings, there's so much you have to do to prepare, and then going to the place, setting up the facility right, making sure that everybody's happy in the facility. And if you're gonna do a program, getting that all ready, there is a lot to do. We've also had declining attendance also. But at the same time, then our virtual support groups have been doing really good. So while COVID has taken its toll on in-person gatherings for everything, people are still looking for that support to talk about their neuropathy. They're still looking for interaction amongst people. I remember after we had one of our first Houston virtual groups, and I was emailing one of the members, and he just said, well, you know, I'm kind of lonely. You know, my wife's out doing something. Can we have a meeting? And so I said, sure. So I sent out an email for everybody for the next day. With that little bit of notice, we had, I think, 15 people show up for just an kind of, you know, instantaneous support group. So it was really meeting a need to have these type of meetings. We could keep our community going. And by doing that, then we're really able to expand our WNA membership. Since before, when we were just basically on the West Coast, we've expanded through Texas, New York, Virginia, North Carolina, Washington, Pennsylvania, Wisconsin, Louisiana. We are all over. And it's easy to go to a virtual meeting, as I just said before in the other presentation. You don't have to worry about traveling. You don't have to worry about the weather. It's accessible anywhere. When I went off and had to go take a little vacation during the summer, I took my computer with me and I was able to attend all the meetings. I'm going to take a cruise in the next month and hopefully try to attend all my meetings from the cruise too. So you really can go and attend everywhere. And then sometimes maybe if you want to attend, but you haven't done your makeup or you haven't done your hair, you can just turn off your video. So you can just listen. And you do have the same type of interaction of face-to-face. When you're with people, you may think it's not the same, but it really does work out that way. And then for introverts, a lot of times when you have people come to meetings and they just want to sit at the back of the room, and you think that you won't be able to do that when you're at a virtual meeting, well, you can do that because, again, you can turn off your video. You can turn off your microphone and you can just sit and listen. I have a lot of people that come to the meetings doing it that way. And I just wanted to add this, though, as a reason to attend a meeting, regardless of what type it is. You go to the meeting usually to help yourself. You want to find out about this new disease you've been diagnosed with. How are people doing their treatments? What's worked? What isn't? But once you do that and you get yourself stabilized, so to speak, stay and help others. That's when you start getting that community going. And yes, so that's what I'll say about that. And this is a picture then from one of the virtual meetings. And you can see we've got 25 people attending. See that bottom row is of people that don't have their pictures on. Some of the people are attending through their phones, and those are through their landline phones. And the people up at the top, I mean, I can tell you who everybody is, you know, and this is Don from Houston, and there's John that recently joined. Here is Joyce from California, who at this instant was taking care of her husband. There's Beth and Ron, Beth from Houston and her brother Ron. Now who's Chris is going to talk later, Helene, who's from Nevada, Glenn, Ed, who's a professor at Texas A&M, Steve, who attends just north of Austin, myself, Marge from California, and all these people. So we are still definitely a community. And the way that you can do a lot of that through Zoom is through the features of it. Just like when we're having our webinar today and we're able to see everybody. Well, you can't see everybody. You can see us, the panelists, through video. When you have the support group meeting, that's also what you can use to see everybody else with. And then you have the audio, you can listen to people, you can turn your mic on and off when you don't want to talk or you don't want to listen. And then you have the chat. A lot of times I think of the chat as having those personal conversations when you're sitting next to somebody in an in-person one. You can have those private conversations when you just want to talk to one other person by using the chat. Share the screen, which you've been seeing us do today. It's a great way to incorporate PowerPoint into your meetings for if you're having a presentation, a program, for somebody to put things up and have it be visual so people can read that. Then they've got polls, which I don't use very much anymore, but they are really interesting to try to have interaction going on because you just ask a question, people give answers, and everybody can see what the poll answers are. There are guidelines that we have in our virtual meetings. We try to make people aware of the time. I mean, all of our meetings, well, most of them are 2 hours, so it's pretty long. And you want to make sure that everybody has a chance to talk. We have kind of rules that if you want to talk, raise your hand or raise your Zoom hand. Use the chat, post comments in the chat, ask questions in the chat. We are always putting links to something, writing out a name in the chat. And be respectful of others. You know, just because a treatment works for you doesn't gonna mean it's gonna work for somebody else, or that it doesn't work for you. It can definitely work for somebody else. So I'm always trying to say, don't tell somebody you need to do this because that may not work for them. And this break at 2 p.m. for stretching, we do try to take a break right in the middle of our support group meeting because it is really hard to be sitting stationary for 2 hours. So this is just a format that I use for my meetings because I know people ask, well, do you have programs and stuff? I don't have programs at mine anymore. When I first started off, I tried to put that in there, but since WNA started doing their webinars, I feel that's where our members and our attendees can get more technical information from. Because really what we want to do in a support group meeting is we want to share with the other people there. We want to share our problems, share our experiences, share our questions. And for the other 2 meetings that we have, when John was talking about this open discussion group, this is what we called it when we started this second meeting where John volunteered to be the host. And we talk about anything in that group. My group is a little bit more structured because I try to be more of a typical support group, but John, and then it's the same on this third Wednesday group. Glenn's meeting is also open discussion. And we did really good on that meeting last time. We had 15 people attend. So now I would like to have some of the members talk about their experiences in the support group, because you've heard me talk about it. I'm telling you everything from my point of view. But I've got Lynn Carpenter, Chris Langenfeld, and Don Tallman, who, can we promote those up to panelists? Is Lindsay there, or do I need to do that? I will do that. Let me see.
I can do it too if you want.
Are you? I didn't know if you were there or not.
Nope,
You can
I'm
do
here.
it. You can do it. Yeah.
Okay. So let's see. So we need Lynn. Let's find Lynn. I'm coming for you, Lynn. There she is. Okay. And then we have Chris and Don. Okay, you guys, so I just gave you
Okay,
more
all
speaking
right, so-
privileges.
All right, now you're supposed to turn your video on.
And
Or
on
maybe
mute.
not.
If they don't want to, they don't have to.
They don't
I
want.
I
They
don't
need to-
have a video to turn on.
Oh, what
That's
happened,
okay.
Lynn? What happened,
Well,
Lynn?
No, I mean, it's usually right here next to my microphone.
I don't either.
That's okay. I can give it to you guys
is
if you
it-
want to be on.
Oh, can you do it? Oh, it's because we're in a webinar, huh?
Yeah, it's a little bit different than a meeting.
Ah, okay.
That's okay. I'll
Okay.
work on that. If you guys have things you want to say, you can go ahead and start.
Well, what I was going to do, and I'll just start with you, Lynn, since you said something.
Sure.
And so what I want to do is I was just going to have, and this is what I do for everybody, have them just say who they are, where they are, and then what type of neuropathy have. So Lynn, why don't you go?
Yes. I would never have found this if you hadn't gone on Zoom. I live near Seattle, Washington, and I just feel like I know all these people so well. I've been a member of Kathryn's and John's group for about a year, and it's I've had neuropathy since the late 80s is when I was diagnosed, and oh, I see I'm supposed to join as a panelist now.
There you go.
Okay, Lynn, now you have to
Unmute
unmute
again.
yourself. There she
Okay.
is.
Hi.
Awesome. Oh, there's Dawn.
Oh, we got Dawn.
Okay. Yeah, yeah.
Okay. sure we
There's
did.
Chris.
Yeah, there's Chris.
Good, good.
Okay, awesome. Okay, awesome.
So anyway, I've had peripheral neuropathy, and it was, the first time I was diagnosed with it, I felt like the doctor patted my head and said, "There's nothing we can do. Take some extra vitamin E and keep moving."
Vitamin E.
I know. So, until it started really hurting a little over a year ago, I just kind of lived with it and went about my merry way. And wow, have I learned a lot about how to deal with the pain and just little things. Like I was taking some alpha lipoic acid, but somebody said, take 2 of them. And I think it helps. I learned all about just exactly what neuropathy is and how to explain it to my family. My youngest daughter just keeps nagging me to keep exercising, and she's sure that I can overcome it if I just get out there and walk 7 miles a day or some darn
Oh
thing.
my God. And Lynn, you were the one that started the plant-based diet.
I did. And I was having those awful electric shock pains in my feet and ankles. Mine isn't bottom of the feet tingling. Mine is more toes and ankles. And then after my, about 5 years ago, I had breast cancer. So I got a little boost with chemotherapy. So now my fingers and wrists. Yes, the plant-based diet stopped those nasty pains. And so far, so good. I've been on it for almost a year.
Almost a year, isn't it?
Mhm,
Yes.
mhm.
And so she's been an inspiration to other people then to go off and try that too.
Well, and some people tried it or have tried it. I think our friend Chris has always been on a plant-based diet and hasn't made a difference for her. So it's like she says, what works for someone doesn't always work for the other. So, but you sure have a lot of options to choose from when you're in a support group like this. And I'm just very grateful that I found you people down in Texas.
Yay. Okay, good. Thank you so much, Lynn.
Sure.
Okay, Chris, so I'm going to go to you next. And so you want to say a little bit about yourself?
I'm located in Houston, same as some other folks, and I have chemo-induced neuropathy. It's large fiber is officially diagnosed, suspected also small fiber and autonomic based on symptoms. The benefits for virtual group is I can attend them. Because I have a very weak immune system, I can't do in-persons. Compounded with the fact that I drive very short distances because chemo also affected my brain processing. So making decisions quickly is very difficult for me. And so driving would be difficult for me as well. Plus, I don't trust my reaction time from the miscommunication of my brain to my feet due to neuropathy.
Oh, yeah.
Now, as far as like benefits that I personally have benefited, I'll just give you two because there's just so many of them. One of them, what Lynn already commented on, was supplements. I amended my supplement regimen, and I've seen actually an increase in energy. Now, I still have my low days, but I have some days where I can get a few things done, which I couldn't before. The other health benefit was from John, because when I came into the group, it was mainly in my feet and legs. It extended to my hands, which there were days I couldn't get out of bed because of the pain. And so what I worked on, John had suggested, was therapy putty. So what I'm retraining is working the muscles and getting them work and try to reactivate muscle memory to compensate for the lack of communication.
Awesome. Thank you. I really appreciate you coming all the time, and I still love your pink hair. Yes. And the third member is Dawn. And I just want to say that Dawn was one of the original Houston in-person group attendees. I don't know how many years you went to the Houston one, but so just introduce yourself, Dawn, tell you where you're from, and let's hear a little bit about your story. Oh, Dawn, you're muted. You're muted. There you go. Perfect.
Okay, hi, I'm Don Tallman. I'm from Houston. I've been going to neuropathy support groups for, I don't know, 10 or 12 years, I guess. Before the WNA Zoom meetings, there was the WNA in-person meetings, and before that there was the NATX meetings, and before that there was a group that I don't know that they really had a name, but we met at a church down the street from the church where we beat down. There's always been a pretty good interest in peripheral neuropathy here in Houston. The original group, I think, would have 75 to 100 people.
Wow.
At some of its meetings. At others, there would be 6, but I can't figure out why. I have had neuropathy for some 20 years. It began in my feet and was never a problem, and then it slowly became a problem. They did a biopsy, an ankle biopsy, and couldn't find any small nerve fibers. That was about 10 years ago. My pain has been largely in my feet at night when I go to bed. And it's been different kinds. It's been the electric shocks. It's been the stabbing pain and all kinds of pain. I ran into problems driving quite a few years ago when I'd been on a highway and was going to take an exit, and I pressed on the brake and nothing happened. That was kind of scary. And then I realized, oh wait, my foot isn't even on the brake. And so that, at least that made me aware of the problem, and I could cope with it. But finally last year, I just gave up driving altogether. I couldn't. I think Chris mentioned that, she can't react quickly, and I can't keep track of a lot of moving objects anymore. So I gave up driving, and it hadn't been too bad.
So Don, one of the things that we do in our group is we're always saying what works for us, just like Lynn and Chris talked about what worked for them. Tell us about acupuncture.
Okay, I started acupuncture in 2016. A neighbor had told me about an acupuncturist, and I had a whole list of things wrong with me. Neuropathy is not my only problem, but I went to this acupuncturist, and I had a list of 8 or 10 things that I wanted fixed, and he went down the list, and he said, well, we got a good chance of fixing this, or we can't help you there. He was really honest about what could be done and what couldn't be done. And as the neuropathy got worse, I asked him to address it, and he did. He's been addressing it now for 3 or 4 years. It is not a one and done type of treatment. It can take a year before you'll see any real results. Although I've noticed that if I've got pain, they can deal with it in 3 or 4 sessions.
And so your balance, hasn't it helped? What, some of the numbness or your balance problems? Which one was that?
It did for a long time. My numbness, started my feet and went up to my knees, but gradually over the year or so that this worked, the numbness went down and down and down. Pretty soon it was below the ankle, and that was pretty good. But it's back. COVID, when I had to stop acupuncture because of COVID, and it was probably a good judgment there. My acupuncturist is 85 years old, so we didn't want to be around each other. When we stopped for COVID, the numbness came back and went back up to the knee, and I think I might have some of it now in my fingers. But it really helps a lot with the pain.
With the pain.
Yeah, and if you go every week to an acupuncturist, they'll probably be able to help you.
Because
do you have a question?
Because of you, Don, I started acupuncture, and it is helping. I've only been doing it about 2 months now, but I'm really excited about, if nothing else, just my whole restless leg situation has calmed down.
It has a lot of benefits.
Yeah.
I didn't even realize.
But I wouldn't have thought of it if I hadn't heard from you. So thank you.
Sorry?
I say thank you.
Oh, sure.
So this is, I'm sorry, I'm going to cut you off, Don, just because we're on our time thing, but I'm going to say that the one thing that Don has also given us has been this great phrase of an experiment of one. We are all an experiment of one. You have to try all these different
neuropathy
things.
Does not affect everybody the same.
Sure.
The treatments do not affect everybody the same. Some people are helped with Noxipure, some are not. Some are helped with acupuncture, some are not. I don't know what all the things are. There's a whole list of things. I've used CBD with good success.
Yes, that's right. Yeah, because I heard about the CBD from Don, and so now I have CBD in my house and I use it mostly for
when the pain is really bad. Spearing some CBD on my toes really will help.
Really helps.
I can at least get to sleep.
That's good. So this is just what I wanted to show that we get with our virtual support groups is the sharing that we get, just like we even did right now, finding out that Lynn is starting to do acupuncture because of the influence of Don. And Chris, I just want to say we have a question that somebody wanted to know what supplements that you started taking that was helping you. Do you remember?
No. I changed my magnesium to magnesium citrate because Glenn had suggested that, and also the alpha lipoic acid. I changed that one. I'm also taking black cumin oil, multivitamin with B12 in it, algae oil. And if you are vegan, you do have to make sure and look at your the supplements to make sure they're not using gelatin or other animal products in them.
Okay. All right.
What kind of magnesium did you say?
What type? Magnesium?
Magnesium.
Magnesium citrate.
citrate,
Okay.
right? Magnesium citrate. And was it the alpha lipoic or the R lipoic acid? You're just still taking the regular.
The R.
The R, yeah. So you went from the alpha to the R.
Mm-hmm.
Because Glenn was saying to all of us that the R lipoic was a better thing. Okay, thank you all so much for talking about your experiences and giving us all some information and telling us more about what we can do with our neuropathy. And we invite everybody else out there to attend one of our 3 virtual meetings hosted by myself or John or Glenn. And you can find all of those in the newsletter or on the WNA website. Okay. I am done with that portion. And what are we at? Who's next? Because
We got to do some spinning of the wheel.
Oh, no,
I
we have to
believe.
do some
Yeah, it's time for another door prize.
Yay! Okay. All right. So
Here's the door prizes again.
we're going to do some more door prizes. And I am
You ready to spin?
I would be if, there you go, thank you, because my new light clicks over the top of the, okay, so wait a minute, so what am I doing? I'm gonna share, oh yeah, okay, wait a minute.
Share the spin
I'm
screen.
getting there, okay. All right, we are going to spin the wheel. Jay Tittle. Jay.
Is that an actual person?
It is a person. Are they on the participant list? Because I can't look at it while I'm doing spinning the wheel. All right, I'm just going to do 2 more.
Yeah, I did not see this person. On
You
the
didn't see
front.
that on there? Okay.
Yeah, I pulled it up. So
Okay, thank you. Spin, 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 spin. And Barbara. I know Barbara's here because we had a
Barbara's
question
here.
from her earlier. So Barbara, we'll go back and we'll see the books and you can pick out which one you want. And let's do spin, spin, spin. I think this thing is so cool. John, you did so wonderful bringing us this. Okay, and which way is it going to go? Linda? Linda good?
Linda.
Is Linda on there?
I don't see Linda.
Okay, so does that mean I need to do another
Let's do
one?
one more.
I'm-
One more or 2 more? One more. And, oh man, oh look, we're going to come right back. James Simpson,
James. I don't see James.
not James either. All right, let's do it again. Let's do it again. Come on. I really should have removed those people's names, but you know, they may show up next time. So I didn't
You
want,
never know.
what is it? We're still going on all the J's.
James again.
Wow.
So I wonder how I can stop. Can I, maybe if I click at a different place on the wheel? It seems like it's just going around and it's going to end up at the J's again. Okay, good. Oh, okay, we went someplace else. Wait, oh, where's it going? Richard A.
Richard. Not here.
Not here.
This is
Mm.
getting some-
I know
getting
people
some-
are here. We're going to
Was it
start
here
changing this
before?
to just the people that are going to be in attendance.
I
All
know.
right, Ed, is it going to
Ed.
go to Ed? I know I talked to Ed earlier.
Ed Doherty is here.
Hey, Ed.
Yay.
Finally get a book on peripheral neuropathy that you want. So is that 2 people or is that 3 people? It's 2
2
people.
I think we had 2, yeah.
Okay, spin, 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 spin. Oh, almost Roxanne. Sue in Pennsylvania, as she always is.
She's here.
Yes, she's here.
Hi, Sue. Woohoo.
Hey, awesome.
All right.
Okay, so that was all ladies, I think. Was that right? So if you want to put the screen back up just for a minute, and y'all can look again, but we've got look and see which one you want. This is the really good one, the Peripheral Neuropathy by Latov. Okay, send a chat, which one you want. Okay. Awesome. What do we have next?
Okay.
We have
Next, we're
Lynn.
going to have some patient stories by, and Glenn Robotsky is going to give us this presentation. Now, Glenn's one of our new directors. Glenn's a lifelong New Yorker, and he holds multiple degrees in psychology and counseling from New York University. He's one of the founding premier tutors at Princeton Review and runs his own test prep company, GGG, and provides content consulting services for others. Glenn was a founder and longtime co-chair of the Runners Advocacy Organization, New York Road Racing Ombuds Association. His acute onset neuropathic experience in 2003 led him down the path of extensive volunteering and advocacy work for those suffering from neuropathy and other neurologic conditions. Glenn is married and has a adopted son from Korea. Glenn has predilections for Arctic dog breeds and fig Newtons.
That's right.
Welcome, Glenn. Glenn has been a fantastic new addition to our board of directors. So welcome, Glenn, and it's all yours.
Thank you. As I like to say, you have to remember fig Newtons are not cookies, they are fruit and cake. So, and that's important to know.
There
So
you go.
I'm going to do a little sharing screen. I put together, yes, it's another PowerPoint that I'm going to try and share with all of you, and hopefully this will pop up quickly. For lack of a better title, it says My Patient Journey, but this is not only going to be about my patient journey. This is going to hit a lot of points about neuropathy as we go. Feel free, by the way, to throw questions into the Q&A. I'll absolutely field them later on. And we'll talk about a lot of aspects of neuropathy. I may even add to a little bit of what our neurologist presented before, based upon research that I have done and the affiliation I've had for a long time with the Cornell Weill Center for Peripheral Neuropathy. They like me there because I'm an interesting patient. And basically the idea is, as I said before, I have a presentation of neuropathy that's rather unusual compared to most people's. It was acute onset, it was body wide, and I am living proof that nerves do regenerate. There is skin biopsy evidence in my case that over the years they have, although probably not to their original status. So I'm going to talk a little bit about how this all came about, and I'll comment as I go. I'll talk about like when this all happened. It's quite old now, but let's see if I can get this to come up. Here we go. So basically, and I remember this like it was yesterday, and I lived on Staten Island, New York at the time, that I first noticed on April 12, 2003 at about 11:30 a.m., because it was such a weird sensation, some tingling and weird paresthetic sensations under the fourth toe of my right foot. I noticed this stepping out of a shower, believe it or not, and I did not know what to make of it. This was not something I'd ever had before. And up until, this point, I was disgustingly healthy. But basically what happened is that as the day went on, this tingling sensation became a burning that encompassed the whole foot. It moved up through the foot. And in 12 hours, it was also starting on the other side and traveling up the right calf. Very disconcerting. Again, I'd never experienced anything like this. The only other nerve symptom I'd ever experienced is basically whacking my elbow on something and causing that ulnar nerve to vibrate for a little while. But of course, that went away quickly. So basically, I didn't know what to make of this, but 43-year-old guy experiencing this, supposedly like, really healthy and stoic, didn't think all that much about it, although it was rather painful. But things got worse over the next couple of days. The burning sensations didn't stop there. They basically climbed up my entire body, eventually encompassing all the skin surface. This, as you can say, is a problem because now the slightest touch was agonizing. Breezes wafting across my skin was burning. Basically, and this is the way I've characterized the pain. It'll be one of the things that'll get me into Bartlett's quotations, if anything does. People ask like, what was it like? So I said, It's like having a severe sunburn over your entire body that's been rubbed with steel wool. I was not able to eat. I was not able to sleep. I was certainly not a happy person. My young son was very, very concerned. My wife was going crazy over this. We tried to begin to find neurology appointments as quickly as possible. But being that I was on Staten Island, and even though I had decent insurance, that took a while. I finally wind up in a local neurologist's office. He shall remain nameless. On April 21st, testing was started. They did the usual pinprick type of tests, the usual reflex tests. I could certainly feel the pinpricks. In fact, I could overfeel them. Reflexes were fine. A lot of blood was taken, urine was taken, appointments were made for an MRI. And I now know, and there's a little indication of this a little bit later on, the suspicion 43-year-old guy presents that acutely is first attack of multiple sclerosis. That's what the presumption was that they were laboring under. And that's why they wanted to do, obviously, all this, particularly the MRIs. Fortunately, they gave me a prescription for gabapentin, Neurontin, some of you know the actual brand name as. And fortunately, from the first 100 milligram dose, some of the symptoms were alleviated, which was great because this was now 9 days in. Finally, I was able to get some sleep that night. I had, not been sleeping, not been eating. I'd lost more than 10 pounds at that point. I was in a bad situation and didn't really know not only what was going on, but if I was going to survive this. I was fortunate that the gabapentin worked. I would actually ramp up the dosage fairly fast. So upshot of this, okay, over the next week, the pain, while reduced, continued. We ramped up the gabapentin dosage pretty quickly. Fortunately, I didn't have that much in the way of side effects beyond a little fluid retention, beyond somewhat of drowsiness, but I was able to handle that. The other, of course, joke about gabapentin is that it'll cause you to lose 20 IQ points. I like to say, fortunately, I could afford that. Not everybody agrees. On April 24th, I went in to get various MRIs of brain and cervical spine. There was no evidence of multiple sclerosis lesions. And because of that, and because nothing was coming back really from the blood workup or the urinalysis, decisions were made to do much further testing as a hospital inpatient at Staten Island University Hospital, which I entered on the 28th. Now, as I said, I'm fortunate that I had good insurance for this, because otherwise I'm not quite sure what would have really have happened. Where am I with this? Okay, so basically inpatient testing in the hospital, more advanced blood work, urinalysis, more MRIs, thoracic and lumbar spine, and spinal tap. They were really looking for those multiple sclerosis lesions. The spinal tap story is fun in and of itself, which actually says a lot about our medical system. They sent in 2 people, very, very tiny, to try and do a spinal tap on me. Now, you have to understand, I'm 6 foot plus, 200 pounds plus. The 2 young nurses they sent in to do this, I probably outweighed the total of them. And they could not find my actual spinal canal. They did 3 punctures at the base of my spine. And I want to tell you that hurt. It's, our presenter earlier on talked about like the discomfort from spinal taps. Discomfort is not quite the word to describe this. And because they couldn't actually find the canal, they then actually sent me down to fluoroscopy for X-ray to actually do it under imaging. And the interesting thing about that was they gave me a local, they did it under imaging. It was done in 3 minutes. To which, of course, I then said, why the hell did you not do this to start? And I was told that apparently insurance won't pay for it unless you can actually show failures in the actual attempt to get the spinal tap. This probably right at that point presaged the coming career I was going to have as a healthcare advocate, because that was enraging. But the gabapentin dose was now up to 1,800 milligrams a day. I was able to be at least a little bit functional. I was discharged back to the neurologist, but nothing came back from the spinal tap or the other MRIs or any of the blood work either. So now basically I have completely normal and negative testing, and I'm still burning, even though I actually have a little bit of functionality now, and I can eat and sleep again to a certain extent. This is where the Princeton Review background helps. For those of you not familiar, by the way, with Princeton Review, it's a test prep organization. It was actually founded in the 80s in contradistinction to Kaplan. I was one of the original master and premier tutors there. Basically, we came up with a lot of the stuff that some of you who have sons, daughters, nieces, nephews studying for standardized exams got the techniques for. Basically, though, it meant that I had access to a lot of medical subscriptions because we do the MCAT. And as a result, I started doing a lot of my own research. First, I realized I was going to have to get some more advanced opinions now at major hospitals in Manhattan, where at least obviously there were research facilities. Basically, I wound up with the New York City Neurology Group, which is affiliated with NYU. That's where I had my first nerve conduction studies. They hadn't been done until that point. I had those and evoked potentials, which is something, again, they will sometimes use to spot MS or other demyelinating conditions of the brain and spinal cord. Still or normal and negative. I do not have sensory disruptions. I do not have blockages. I do not have motor symptoms, just the severe burning dysesthetic pain. Now, of course, owing to the fact that I'm doing so much research, I come across through things like PubMed and a number of the other aggregators of the medical situations, some of the papers that indicate that this could be an attack of small fibers. I basically eventually, reading several dozen papers, come to the idea that I may have experienced an acute onset autoimmune molecular mimicry small fiber nerve attack, analogous to Guillain-Barré syndrome. And for those of you not familiar with all that, the idea is that your body is invaded by a pathogen. And I had a cold a couple of weeks before all this started. The theory is that your body produces an immune response, probably even fights off the pathogen. But if the pathogen has a molecular structure similar to some component of peripheral nerve, the now activated immune system no longer can tell outsider from insider and attacks any body tissue that looks like that. This is thought to be the mechanism beyond Guillain-Barré syndrome, which is an acute neuropathy that basically attacks myelin sheathing as well as the axonal interior fibers. It usually is directed against particular components of myelin. And as a result, and I'll talk about this a little bit more later, that's why it often has motor symptoms in addition to sensory ones. These small fiber nerves are the nerves that subsume the sensations of pain and temperature. They are not covered by myelin sheathing. Myelin sheathing does cover larger sensory nerves that subsume the sensations of mechanical touch, vibration, and position sense. And myelin also covers all motor nerves, which you usually find in those larger nerve cords that our neurologist spoke about earlier. But the other thing that I learned is that while there are other tests for small fiber neuropathy, including qualitative sensory testing and pseudomotor axon reflex testing, which is that one where they cover you with the purple powder to see how well your sweat works, because autonomic functions like sweating, pulse, blood pressure are also controlled by unmyelinated small fiber nerves. The real gold standard, at least in 2003, still really is, was skin biopsy. This is not the same as nerve biopsy, which normally takes a large sample of a myelinated nerve, usually at the ankle. Skin biopsy is often done in the upper arm, the thigh, and the lower part of the calf. And what they're looking for, and it takes an electron microscope to see this, is the density of the small unmyelinated sensory nerves and what condition they're in. So I managed to wrangle an appointment at the Cornell Weill Center for Peripheral Neuropathy, which is one of, at the time, 2 New York City medical centers that does this procedure. The other one, of course, is Columbia Presbyterian. They're both under the New York Presbyterian umbrella, but Cornell was closer and has a research facility. So basically, I wound up in there on July 23rd. Most extensive physical I will ever get. Fortunately, one of the advantages of going to a major research hospital with a research orientation into peripheral neuropathy is that the doctors can spend time with you. They're not being paid by the patient. So basically, it was a full exam, not only neurological. They did everything from an EKG to basic, testing of, just general lung function, and some highly detailed neurological testing. It's where I was first introduced to something called a von Frey hair, which is a small filament. They have filaments of basically different calibers and thicknesses to see what you can feel when they touch them to you. So it's more than just the usual pinprick test many people are familiar with. Advanced autoantibody blood work. What Cornell is most famous for under Dr. Norman Latov is discovering a lot of the autoantibodies to peripheral nerve components. So they basically tested me for all the ones they were aware of there. And of course, the skin biopsy. I had actually explained what I thought was going on to the neurologist there, and they seemed to think that there was a pretty good supposition on my part. They asked where I'd found out about that, and given the eidetic memory I have, I basically quoted them chapter and verse, including some papers that they weren't as familiar with that came out of Europe. And basically, we waited for the results about 7 days. All the testing was normal except the skin biopsy. There was significant reduction in intraepidermal nerve fiber density. I was at the 3rd percentile. Anything below the 5th is considered definite evidence of small fiber neuropathy, although you can have the amounts, really percentiles above the 5th percentile and still get a diagnosis depending upon the condition of the fibers. And mine were in really bad shape. There was evidence of swelling and degeneration. One of the doctors there said that some of them looked like they'd been exploded from the inside. This was the only test that I had ever had, and I've had so much of it, which provided unequivocal evidence of neuropathy. Okay, so the upshot of all this, okay, now is basically without direct evidence of autoantibodies, which is going to be interesting, I'm sure, when John talks about his journey tomorrow, immune modulating therapies were not recommended. I can tell you that Cornell does things like IVIG and plasmapheresis quite commonly if autoantibody activity can be demonstrated. But since I did not, and the supposition was that the autoantibodies that might be involved might be unique to me and not necessarily having been even discovered yet, treatment was going to be palliative, okay? They did suggest that since I had acute onset symptoms, there was a strong possibility of regeneration. Turns out they were right, and we'll talk about that. We increased my gabapentin dosage to 2,400 milligrams a day, which I stayed on for about the next year and a half. Now, there's a good news, bad news aspect to this, which I'll talk about. I had follow-up appointments at 6-month intervals for the next 2 years. By early 2004, symptoms began to reduce slowly. And so under the medical supervision, I began to slowly ramp down the gabapentin dosage. It took me the better part of 9 months to do that. I basically was going down about 100 milligrams every 2 weeks. The reason you do this is gabapentin was originally developed as an anti-epileptic, which basically means that there's a chance if you go and wean down too quickly of getting rebound seizures in addition to increased pain. Nobody wants that. But I was able eventually, by almost the beginning of 2005, to get down to a 0 dosage. Still had some symptoms, but nothing like they originally were. And then, of course, since I'm such an interesting patient, they did a follow-up skin biopsy at the 2-year mark. I was up to 17th percentile of intraepidermal nerve fiber density at the locations. The good thing about skin biopsy, where they really just take like a 3 mm patch of skin and then just slap a Band-Aid on it, it's not like the nicest thing you'll ever have done to you, but it's much less invasive than a nerve biopsy. And it can be repeated over time from the same areas. So, and I've been getting, by the way, subsequent skin biopsies about every 3 years since. I'm up to, at this point, about the 30th percentile. That's considered normal. You just really don't know in the end where you started, because except for some research problems, particularly at Johns Hopkins, where these norms were first standardized, people who are experiencing no symptoms don't go for skin biopsies. So let me see, what did I actually skip over here? Here we go. So basically now, and we're going back now about 19 years, symptoms have greatly waned over the years. Subsequent skin biopsies show slow but continued nerve regeneration. My symptoms are about 90% gone on a good day, maybe on a bad day, 75%. I'm still prone to flares and compressive nerve effects due to regeneration in alternative pathways. The theory, of course, with this type of stuff is that when nerves regenerate, particularly the small fiber nerves, they have to fight their way through and around other tissues, and they will not wind up in the same pathways that they originally were. So it's very, very easy to compress them and cause symptoms. In fact, a lot of people who've been through this, now that I know from various communities I've been involved with and boards I've been on, is that a lot of people will often have upticks in symptoms for a while, even during nerve regeneration. And of course, the people who have traumatic neuropathies from injuries and then have nerve healing report very much the same thing, that they'll have extensive flares that go on for weeks or months and then gradually subside as the brain gets used to the new signals that are impinging upon it. It turns out that what happened to me is somewhat rare, but it might be considerably underdiagnosed. Due to my and others' similar histories, the descriptive entity ASFAN was coined. I have actually been talked about in medical papers, although they usually don't mention the name, due obviously to confidentiality issues. But sometimes when people bring up a paper, I will actually tell them, yeah, I was part of that study. ASFAN stands for acute small fiber axonal neuropathy. It's a great acronym. All we need is one more S. But basically, what this actually showed was that there are weird presentations of neuropathy. Yes, it's probably true that the majority of people have the slow on of diabetic neuropathy, starting from the toes, working its way up, maybe getting into the hands and fingers. But it's not the only presentation of neuropathy. There are acute onsets. There are subacute onsets over weeks to months. There are people who experience symptoms first in other parts of the body. It's not always toes and fingers. And of course, all this I have learned through research. I'm fortunate to have been born in an internet era. I'm fortunate to have access to a lot of medical sites. But understand that before all this happened, I knew nothing about this. Okay, there was not a thing that I could have told you. I hadn't even heard about what neuropathy was. And it's the reason why, as at least the symptoms, wound down enough for me to become involved, that I became involved in the Neuropathy Association, which unfortunately is now defunct. I was part of a very important neuropathy summit in Washington, D.C. in December 2010, which was I first met Bev Anderson. And basically since then, in various ways, shapes, and forms, I've been involved being an advocate for knowledge about neuropathy. It's the most common ailment that nobody knows. It's estimated 1 in 15 people will experience it over the course of their lifetimes. And unfortunately, part of my advocacy work led me to the conclusion that our organizations were small, not well funded, and often didn't play well with each other. A big part of my getting involved with WNA is to be a liaison and help the organizations play well with each other. So this is a story. Yeah, obviously, it's mine. It's unusual, but I think it provides some hope as well. Neuropathy is not necessarily something that is going to be everyone's fate for the rest of their lives. There are ways, if one can find a cause, and if it's a cause that's treatable, to actually treat it and reduce symptoms. Yes, there are people out there labeled as idiopathic, although I suspect that a lot of those people labeled idiopathic, from, again, the research that I've been privy to with Cornell and other places, is that there are autoimmune or metabolic mechanisms involved that just haven't been described yet. There may also be genetic causes involved. The Human Genome Project has revealed innumerable small groups of hereditary neuropathies. There are so many of them that the database to list them, the best database I know, by the way, I'll talk about this tomorrow, is at the Washington University at St. Louis Neuromuscular website. Since I first started consulting on that website, the number of hereditary neuropathies listed has quintupled at least. That's what we're discovering genome-wise. So there's probably still more of them out there. There is definitely evidence that people who have dysregulation of glucose that's not frank diabetes may suffer neuropathy even before diabetes is diagnosable. And of course, there seems to be more and more autoimmune neuropathies diagnosed as we learn more and more about autoantibodies. Again, more of this we'll talk about tomorrow. And obviously, people who have questions or want to know more about this, I will obviously field them. But I have, at this point, considerable expertise in this. Doctors consult me, I'm very proud to say. There are people in like the heart units at Staten Island University Hospital that call me when they have a neuropathy question. And a lot of this is due to having an eidetic memory, as I said, so I read sites and I just remember it all. But I do tell people that in the end, that it's not, for most people, not only not a death sentence, but it's not necessarily a complete morbidity sentence. And I'm hoping that with obviously advocacy, with more money into research, we'll have more and more treatments that are actually developed, and not just palliative treatments that will actually help heal nerves. Nerves do heal. They heal extraordinarily slowly. Under the best of circumstances, 1 millimeter a day is a figure that is often quoted. Of course, that means if you've got like a small fiber that goes from your lower spine to your toes, you could be talking about 3 to 5 years. And that's only, of course, under optimal conditions. But it is possible. And, I try and tell people that, there is hope for this, for the people earlier during the presentation worrying about when are we going to have a treatment. I think one day we will, or we'll have multiple treatments for multiple types of neuropathies in the same way they're going to have multiple immune modulating treatments for many different cancers and autoimmune diseases. So I figure I'll sort of like, sum it up at this point, let people throw questions at me. I'm looking to see like what we have. I should basically at this point kick out of the screen share unless anybody wants me to keep it up. I'm looking into the chat. I want to bring that up if I can. Let me see if I can do that.
I just want to say
Yeah.
that really Glenn knows so much, and he is like our medical expert when we have our virtual support group meetings. Somebody will ask something and I'll go, Glenn, do you have an answer? So really you have the opportunity now. He's here. If there's something particularly about your neuropathy that you'd like some more information on, or some term you don't understand, Glenn will know.
Yeah. It's
Or
time,
John will know.
It's
Glenn
yeah,
or John.
or John, yeah, or John will know. It's time. It's time to pick brains, basically.
One of them will know. I'll just point the fingers and say who's going to talk.
Yeah.
So We did
I'm
have comment. I mean, Katie said your talk was fascinating.
Mhm.
So that's good.
Were there any questions from before with Dr. Zhang that maybe either of you wanted to provide more insight on, or something that she maybe glossed over that you thought could use some more detail?
Well, I could talk a little bit about the say the impaired glucose tolerance situation. There is a lot of medical literature out there, and if anybody wants to, I could probably flood your email box with it, that seems to indicate that given the upturn in diabetes and in impaired glucose tolerance before frank diabetes, that there are a lot of neuropathies that people think are idiopathic that may be caused by this. There's demonstrable small fiber nerve damage in people before they actually get to a frank diabetes blood sugar level. It's another reason why I tell people that even if you have a neuropathy that is not diabetic in nature, it's good to treat yourself as if you are. You know, watch that sugar intake, keep your hemoglobin A1C in a very nice level if you can. You try very, very hard, you know, to maintain a good diet. Try very hard to build muscle. Muscle is less insulin resistant than other tissues if we're talking type 2 diabetes. You really want to try, you know, especially since as we get older, obviously, we tend to just lose muscle tissue just as a result of aging. But you can't build muscle with age. I certainly have. You know, you got to commit to it. You got to lift weights, you know, and you got to do, even if you do, you know, light weights and many reps. But that's as important as the aerobic exercise we all need, just because you want to make sure that you have that tissue there that helps to regulate your insulin and glucose levels. The other thing that I could make a mention on, somebody had asked a question about cryotherapy. There are certainly people out there, most of them not neurologists, I wouldn't think, but there are, say, chiropractors and physical therapists who do sort of nerve ablation therapies. You know, sometimes they do it with cryotherapy, with nerve freezing. Some people do it with lasers and heat, where basically they're just burning off the offending nerves. I don't know how effective that would be for a systemic peripheral neuropathy, though. If you have a, say, what they call a mononeuropathy, you have a pinched nerve that you just can't get released, maybe if they burn that nerve ending, that helps. One of the actual conditions, a neuropathic condition that I know of that they use this for, is something called neuralgia paresthetica, which I don't know if any of you know about. It basically involves the compression of the lateral femoral cutaneous nerve, which is a nerve that comes out of the back of the spine, down the sides of the buttocks, and into the outside of the thigh. It's a purely sensory nerve, and it doesn't go beyond the upper part of the knee, but it is very easy to compress that nerve because of what goes on in the pelvis, which is very crowded. So people who have, say, lumbosacral issues or have pelvic issues, this is a common mononeuropathy. There has been some success with cryosurgery for that because it's a fairly large nerve. It's easy to spot, you know, on fluoroscopy, and you can actually like burn off the end of it. Although the problem with it is that, again, nerves can regenerate over time. And if you're a healthy person and that nerve regenerates, you may have the symptoms again. Kathryn says.
So there's 2 questions in the chat.
Okay, Okay, I've had neuropathies for about 2 or 3 years, but I'm getting little guidance on what to do about it. How do I find a place to go to or a doctor to go to help me make progress? A lot of it, Michael, will depend upon where you live and what's available. And of course, what insurance you have, which of course I feel depressed every time I say. I am of the opinion, okay, and I realize this is not universally shared, that if one has a neuropathy that's idiopathic and is not getting a lot of guidance and is mostly seeing neurologists in private offices, it's well worth getting a second opinion from a major teaching hospital, particularly one with a neuropathy center. Among those, obviously, there's some in New York, there's Cornell and Columbia, Massachusetts General, Jacksonville Shands in Florida, the Jack Miller Center in Chicago, the Mayo Clinic either in Arizona or Minnesota, whatever you're closest to. In California, one of the best places is University of California, San Francisco, which is where Ann Poncelet, who I'll introduce you to tomorrow, has worked for a very long time. These are all major centers of research into neuropathy. And although the waiting list might be long, it's not a bad idea to try and wrangle a second opinion consult there. Often these are places where they can do advanced autoantibody or other testing. They may have other ideas about, like, doing genetic testing for certain causes. So that's, basically what, I try to recommend. And I realize, yes, it may be hard, obviously, if you're in a small rural town in West Texas, it may be hard to do this. But Michael, if you want, you can tell me where you live and I could probably give you some suggestions. At least places that are close.
And the other thing is come to our virtual support group meetings, because we have lots of people that are newly diagnosed that get the same diagnosis of you have neuropathy, you have to live with it. And they come to the meetings and listen to what everybody else does with their neuropathy. And you can learn a lot in the meeting, especially since you've got Glenn and John there. And so that's something else I suggest if it's not possible to go off and get to a doctor. Glenn, someone asked who was the UCSF person that was Poncelet. What is her name?
Yeah, Ann Poncelet. I don't know. I wonder if I could pull up real fast. I mean, you will see this tomorrow when I do my presentation.
Don't do it. I'm saying don't do it because we've got more questions. So
okay, but Ann Poncelet wrote a wonderful paper. It's about 24 years old now, but it's still excellent, called An Algorithm for Diagnosing Peripheral Neuropathy. It has wonderful charts and wonderful flow through situations there, and it's a very, very good starting point for, given whatever people's symptoms and test results are, what they should be doing next. And Lolene is asking about chemo-induced, right?
Well, kind of. She's saying, yeah, that her. So does chemo actually kill the nerves when?
It certainly can, but don't take their word for it. All right. I certainly have experience with people who have had chemo, who have gotten regeneration of other nerves around dead nerves that took over the function. The idea, of course, first is chemo has to be over, because if you keep doing it, you won't be able to do it. And then you really have to try and maximize your oxygen and nutritive abilities. You want to do exercise, to improve circulation, because obviously the more circulation, the more oxygen and nutrients you can get to the nerves that are still in the area, and the more toxic waste products can be carried out of there, the better off you will be. Yes, I agree. Chemotherapy is a major neuropathy pain. A lot of oncologists don't even mention it when you start those heavy metal or other, neurotoxic regimens. They really should. But most people with chemo-induced neuropathy over time, and it may be a lot of time, so I apologize for that, will get some function back, although, as with many other acute onset neuropathies, the function is often patchy and incomplete. But since nerves can regrow, you can get nerve fibers into areas where others have been killed. And it may be a very, very interesting and weird set of sensations while that's happening. But, depending upon Lolene, how long the chemo's been over, if you can get your nutrition optimized, you may get some function back in time.
So
Michael just said he lived in Connecticut. I'd absolutely say come into Cornell. There are people there I can tell you to see, even if you're in Upper Connecticut, or if you're in Upper Connecticut, you want to go the other way, in Massachusetts General, MGH.
There's There's a question, go to the chat box. There's a couple of people that asked something. Judith asked specifically about your story. She said the only treatment you had was gabapentin.
Yep.
How would this have helped your nerves regenerate? Also, have you experienced onset tick by something tumor in the spine?
Okay, to separate these into three questions, which I can
Yes.
address. I'm sure gabapentin did not help my nerves regenerate. I'm sure what happened is that basically the autoimmune process burnt out sufficiently that my body's own ability to heal slowly and naturally eventually helped do some healing. The gabapentin was for palliation only. It's basically for just removing some of the symptoms while things were going on. Now, have people had experience with onset after tick bite? Oh, you better believe it. Lyme disease and a number of the other brucellus tick-related diseases are known neuropathy producers. There is some question whether it's from the actual invasion of nerves by the bacteria itself or through an autoimmune molecular mimicry reaction. It could very well be both, for all we know. And what is it? I can't even pronounce things.
I know.
Schwannoma tumor in the spine. Well, that is actually going to produce neuropathy through compressive forces. I mean, that's not as systemic a neuropathy, although depending upon where in the spine it was, you could get symptoms really from any level at or below where the tumor is. I always tell people, because I also have the problem of cervical spine difficulties. I have arthritis and disc problems there. And those symptoms are actually very different from my small fiber neuropathy. There's a lot more like tingling, motor, occasional numbness, which I did not have with the small fiber neuropathy attack. It's transient though, as long as I keep really working with the physical therapists and doing the exercises and doing the traction. I've managed to stay out of the operating suite for about 15 years. Most of it, by the way, is because I was an athlete in my youth and I used to play rugby. Rugby, for those of you who know it, is football without equipment. And it's probably, no great surprise that I have cervical spine issues as a result.
Yeah.
When you're 17 and you're an idiot, you'll play rugby.
Okay, Glenn, one more question. The other question in the chat, Kathryn asked, how would we go about getting a skin biopsy at Kaiser, which is still California? But she says no feeling in foot or ability to
circle ankle. Yeah, I mean, I have no idea. I don't know if Kaiser does skin biopsies. You may not be able to get it from Kaiser. You might have to go someplace else to get it, or have them recommend you up to a place like UCSF or one of the other facilities. Basically, anybody who has, and this is, I'll talk a little bit, not specifically to rhabdomyolysis, anybody who has an autoimmune molecular mimicry blood disorder is prone to neuropathy. My wife, until recently, worked for the Lupus Research Alliance, and you'd be amazed at the number of people with lupus who have neuropathy, and the number of people with related diseases such as this one, and Behçet's, and polyarteritis nodosa, and scleroderma, who actually have neuropathies as effects of these diseases. Some of it is from compression. Some of it is because these are diseases where there's autoimmune attack on blood vessel material. And so basically blood vessels are compromised and you wind up with, again, lacking nutrition and oxygen and toxic buildup of waste products. We've often talked about there's over 200, causes of neuropathy. Certainly with the hereditary ones now, there's a lot more. But a lot of the ones that are more well-known, or at least should be well-known to specialists, include these autoimmune molecular mimicry vascular disease conditions. And like I said, many of them are related. Some people argue that they're different manifestations of the same underlying mechanism, which is autoimmune attack on blood vessels and connective tissue. What else do we got?
That's it. Well, we're just about out of time. So this is perfect, Glenn. You took us to 3:56. So We've just gonna do door prizes again and get our update on fundraising and then go for tomorrow. So
Yeah, and thank you, Glenn. That was
I'm
really
gonna say
good.
very
Thank you.
good, Glenn,
Yeah.
as always, very educational.
No problem.
Fantastic.
And we'll, as I said, some of this we'll cover again a little bit tomorrow as we go over the neuropathy advocacy type of stuff. You guys are going to learn about the organizations, but also you can get a lot of the information that I have gotten over the years.
Yeah, it's
Okay.
very good.
Good. Thanks.
All right. So let's do some more door prizes. So.
All right.
All right, so everybody look at the books again. And if you don't pick anything, I'm just going to give you the Peripheral Neuropathy book by Layton. Okay, so which is the best one?
That's a good one.
Yeah.
And yeah, and so Daryl, if you could just stop sharing because I can't get my cursor up there. To
Oh, I'm
stop
sorry.
sharing. No,
There you go.
it's just that I can't. It won't do it. All right, so where am I going? Okay, so there I'm going. Okay. All right, so let's go. 3 more people. And Dana.
Oh,
boy, that was so
Daryl.
close.
another Daryl. Daryl is not on.
Daryl's not on. All
Daryl's
right.
Not on. Sorry, Daryl.
Okay, Daryl. Let's see. All right, maybe it'll come back to Dana again since it likes to stay the same. See, it's gonna come back almost the other side of Dana. And
Tatar is
It's
not
Tatar.
on.
he's not on either.
And
All right,
we could
I'm-
give it to him, but
I'm gonna make an executive decision and I'm gonna give it to Dana. Is Dana on? Is she still here?
Dana Delgado?
Yes.
Yes, she's on still.
Okay.
Hi,
All right. Dana, you get it. So you're gonna be the first one since you went all around your name.
Dana.
Eventually we're going to get to Oprah. You
Yeah.
get a book. You get a book.
Okay. Oh, Rick.
Oh,
Oh, Roberta.
oh, Roberta.
Is that
I don't
Roberta?
Oh, I don't think Roberta's here. Is anybody?
Roberta.
No. Okay. Yeah, I don't think
That's right.
she's here. Okay. Spin. Come on. We still got like 35 people here. Come on. Come on. Pick one of the ones we have here. I don't remember seeing Shirley's name either. Do you see it?
Don't know.
don't
I
see
don't
it.
have Shirley.
All right. See, but Stephen on the other side, he's here. We're just so close to getting everybody on the other sides. All right. Is Lisa?
Lisa is
Yes,
on.
yes. here.
Okay.
Lisa.
Hey, Lisa, you're a winner.
From the north, from the far north. Okay, so Lisa, tell us which one that you want, and then we'll go one more time and get our third one. Let's see. Oh, see, and it's all going to the same place. You know, because we said that
Shirley
Shirley's
to win.
not there, right? I mean, I don't know how to make it. That's really
Yeah, 'cause
interesting.
we don't want to take them out in case they come on tomorrow.
Yeah, I know. So I didn't take them out. Okay. Oh, let's go to Helene. See if Helene should.
Helene.
Yay.
Yes.
Yep, Helene's here.
Okay.
Helene, you're
All
our-
right.
Although
You're
I
a
do
big
wonder,
winner.
Helene.
I do wonder if Helene has a lot of those books.
Well, she may, but I don't think she has all of them. So Helene, you win. So you go off and put them up. All right, we've got plenty of these. If everybody wants to have one of these by Latov.
So
Okay.
Helene and Dana
And Dana.
and who was our third?
Who did I say? it
Lisa.
was? Lisa.
Lisa. So you three will be picking a book from the screen
Yes.
and let us know which one you
And
want.
let us know which one you want.
You can send it in
Mhm.
the chat and we will get it to you.
Awesome. Okay, so, and now we're coming towards the end. Go on to the next slide. There you go.
There we are.
Update from Lindsay.
All right. So
Drum roll.
Drum roll.
How are we doing?
let's see. So as of today, we've got $1,700 of our total
Excellent.
2,000. So since we had Kathy's donation, we got an additional 700 in. So that's awesome for our very first day. So we're
That
only
is
300 shy from our goal. So if anybody
Okay.
else wants to donate today, or tomorrow, by all means, you can keep sending in your pledges. You can email me. You can donate directly through the website, and I'll provide that info for you guys again. But I just want to do a shout out. We had a couple donations come in from Texas. We had one from San Francisco and another one from Sacramento. So thank you to everybody who's donated so far today and sent your pledges. It's awesome. It's a great start to our goal. So yay.
Very good.
So by all
Very
means,
good,
you can
very
keep
good.
sending in additional pledges. You can go into and send it directly to my email, which is admin@pnhelp.org. Or you can go to our website directly if you want to donate now with your credit card, or you can send in a Q&A, a chat to the panelists and send us a pledge there.
Awesome.
Okay,
And also,
very good.
I don't know if I said in the beginning, I'll totally say it again. We are recording everything that's happening today. We
Oh,
cover all of
great.
the
Yes.
presentations. And after the conference concludes, then we will post all the recordings to our YouTube channel, and we will get those out to everybody that attended, so you can re-watch anything that you might have missed or just want to re-watch for fun.
Great. Great. Thank you.
Yeah, of
Thank you, Lindsay.
course.
Okay, so let's see here. Where am I?
You're at closing remarks.
Okay, so first off, we want to say thank you very much for attending. We hope that this information that we've been able to get to you today has been helpful. We want to ask you to join again tomorrow for another day of information, education, and sharing and hope. Tomorrow, we will look at an update on Dr. Hammock's pain medicine and the status of the clinical trials. And then at noon, we'll have Glenn Robotsky give us another talk. This one will be on tools for patient advocacy. And then at 1, John Phillips, one of our newest director, will give a talk on patient stories. And of course, we'll have a number of door prizes. And then we'll have the end of the conference about 2 o'clock. But we look forward to having you participate and look forward to your participation on an ongoing basis. Please remember today at the end of the conference, which is in a few minutes, that you please complete the survey.
Yes, you should get a pop-up prompt before you click exit. That'll come from Zoom. It's really quick. It's only 3 questions. So it's just a real quick feedback to see how we're doing and how you liked the presentations today. But go ahead and complete that, and we'll see it when we close out the day.
Wonderful.
All right, well, thank you. And again, thank you very much for attending. Please have a wonderful afternoon, and we will see you tomorrow at 11 o'clock Pacific time and 1 o'clock Central time. Thanks again. Bye-bye.
Thank you,
Bye,
everyone.
everybody.
Bye, everybody.